Good morning. Who is it?
Dr. Ram here.
Okay, yes, it's Ram. I didn't see them. Okay, because they were sharing the screen. Good morning. Good morning.
Good morning, sir. Good morning.
Quite some time, no?
Yeah, yes, sir. Due to the corona times, we are not meeting. Only in webinars we are meeting.
How is things?
Hello, Dr. Ram Gopal.
Hello, hello, hello. Nice to meet you.
My pleasure to see you after long time.
Yes, sir. Yes, sir. How are you, sir?
I'm good. How are you, sir?
Fine, fine. Going on.
How is ma'am?
Madam is fine. She's there as chairperson, I think.
Okay.
Dr. Bhavan is facing some challenges in joining. So I have sent him the link again. So he'll be joining.
And what about Dr. Srutika?
Yeah.
Srutika Thakur?
We'll just check. She's not there with us right now.
Komal, I don't have her number.
Okay, sure.
We'll call her. Samath Hospital. Who is from Samath Hospital?
Sadi Madam's hospital only.
Achha. Sadi Madam is from Samath Hospital.
Ram is also there.
But they were checking the one more number is there, no? Samath.
Hello. Yeah, Dr. Shrutika.
So it is almost time, sir. Should we wait for another minute or two?
2 minutes, 2-3 minutes we will wait.
Yeah.
She will be joining in 5 minutes.
5 minutes.
Dr. Shrutika Thakur.
Sadi Madam, we will start.
Should we start, sir? If you allow me.
Madam, okay, no? Sadi Madam, we will start, no?
Yes. But
Great.
Shrutika has not come. It's already.
By the time we start with the introduction, CVs and all, she will be here, I hope.
Okay.
Right?
Yes. Okay.
Okay.
So let us start with all of your permission. So good morning and welcome to this Sunday morning webinar. It has been a fantastic day here in Pune as well as in Kerala. We are proud to host you. I am Dr. Amit Borse. I am Head PMT and Medico Marketing Initiatives at IVA, a division of Emcure Pharmaceuticals Limited. Me, along with Ms. Komal Kanodia and our director, Mr. Nikhil Mehra, will be the host for today. We are very thankful to Central ISAR and Kerala Chapter of ISAR to give us an opportunity to host this event. Before I go ahead, may I ask my director, Mr. Nikhil Mehra, to say a few words?
Good. Thank you, Dr. Amit. A very warm Sunday morning to everyone sitting out over here. I am Nikhil Mehra. I am working as a division sales head with Emcure, with IVA division, which mainly deals into infertility basket. On behalf of Emcure, we would like to take this opportunity to thank Central ISAR, Kerala ISAR chapter, all the faculties and delegates sitting out over here. Just a small glimpse about Emcure. We are the global integrated pharmaceutical company having presence with more than 70 countries worldwide. We are 12th rank in India and the fastest growing pharmaceutical company and number 1 in the field of gynecologicals and a very preferred partner in the field of infertility management. Thank you, everyone. Looking forward for the wonderful event today. Over to you, Dr. Amit.
Thank you, Nikhil sir, for your 2 sentences. And indeed, Emcure is a pioneer in the field of gynecology and IVF. Materna is our lead brand and is an epitome of quality and success. Before I take this over, I would like to I'd like to introduce Dr. Sathi ma'am and Dr. Faisal Louis sir for this. Komal, can you just place the CVs? So Dr. Sathi M. Pillai, ma'am. Next, CV Komal.
Yeah. I just want to wish all of you good morning. I am chairperson of the Kerala ISR. I and along with FESI welcome you all to this webinar. And the webinar is on two topics: management of ART pregnancies and gonadotropins in IUI and IVF. Let me also thank Prakash Trivedi, the Central President and Secretary, Dr. Kedar, for helping to arrange this meeting in Kerala, and my special thanks to Aiva MCure for conducting this meeting. So, if no further, or FESI, over to FESI. FESI,
Dr. Spacey, sir, you'll have to unmute yourself.
Hello, good morning, madam. Thank you, madam, for the introduction. And I think, as madam told, it is a proud privilege to be part of this All India webinar of the National ISAR. I think we are the first state to host this webinar by the MCure National State Chapter ISAR. And there will be two panels in all the webinars. The topic today, as madam told, is the one is the ART, the pregnancy management after ART, and the other is the use of gonadotropin for ovulation induction. And thanks, President Dr. Prakash Trivedi and Secretary Dr. Kedar Ganla, who took the initiative, and they had formed a specific module for this. And I take this opportunity, with permission of madam, to introduce that we have right now 50+ members in our state body, and we have 22 new applicants for our state chapter and the National ISAR membership from Kerala. And they were applied for that, and it is a process of getting approved from the next managing committee. It will get approved. So with the permission, I am introducing them. One is Dr. Siddiq from Kondoti, Dr. Sneha and from Trivandrum, Dr. Kavita Leela Submaran from Kayangulam, Dr. Simi Harris, Trivandrum, Dr. Shiba Joseph from Calicut, Dr. Chaitra from Cochin, Dr. Sangeeta from Kannur, Dr. Parvati Taradevi from Kayangulam, Dr. Suma Vishnu from Sultan Bathery, Dr. Roja Shaji from Tarasheri, Dr. Minu Priya from Kollam, Dr. Pradesh Rajendran from Talitparamba, Dr. Deepthi Prem from Kollam, Dr. Ajita Hari from Paripalli, Trivandrum, Dr. Hari Prasad from Kannur, Dr. Nisha from Trivandrum, Dr. Rabi from Calicut, Dr. Anju Mahadevan from Kollam, Dr. Veena Chudamani, Trivandrum, Dr. Venugopal from Talasheri, Dr. Ashish Bench, Kannur, and Dr. Thomas Paulos from Kochi. So I think it is with proud privilege, I have to announce that we have 40% rise, more than 40% rise in our membership in this year. I think this will continue. I think this is one of the prime organization of the infertility specialists of India, and we were happy to conduct the national conference in 2010 also. And I think this will take for a more forwarding, spreading the knowledge of infertility and conducting the CMEs and awareness among the gynecologists. And I hope more and more gynecologists will come and join our Indian Society of Assisted Reproduction. I think with this, we will go into the scientific session. As the first panel, we have pregnancy management after ART. And can you show the moderator is none other than Dr. Girija Wag from the Pune. Can I have Dr. Girija's CV? We have 1.5 hours of panel discussion. With the last 15 minutes, we will try to, if possible, we will try to take the chat from the questions from the viewers, so that it will be more interactive session with more just like a physical CME where panel discussion occurs. We will have a healthy discussion with the viewers also. Can you show the next slide? Dr. Girija's CV, please, Aman, and the panel members.
Yes, sir.
Okay, our moderator for the first panel is none other than Professor Girija Wag. She is Professor Department of Obstetrics and Gynecology, Bharati Vidyapeeth Medical College and Hospital, Pune, Senior Consultant, Cloud9 and Apollo Hospital, Pune. faculty professor of OGISH, International Expert General Coordinator, and Chairman Medical Disorders in Pregnancy Committee of FOGSI from 2012 to 16, Vice President Indian Chapter of Justice since 2014, a member of governing, was member of Governing Council of ICOG from 2011 to 14, Joint National Secretary of FOGSI in 2010, All India, and Assistant Coordinator National Eclampsia Registry since 2008, member Central Supervisory Board of PCP NDT 2010 to 14, National Mentor Lakshya, and another MOHFW of Government of India, and Anandbhai Joshi Award for Excellence in Medical Service. And the topic is Pregnancy Management IRD, and the panel members are, can you show the next slide? First is Dr. Bhavin Balakrishnan. Bhavin is a teacher for postgraduate studies of obstetrics and gynecology. He is a MD from University of Mumbai, Diplomate of National Board of DNB. 1995 thesis on balloon mitral valvular plasty in critical mitral stenosis during pregnancy. 1998 7 gold medals. In 2004 Asia Pacific Society for Fertility and Sterility Award. In 2006 Free Mason Lodge, and 2006 invited journey to understand the social and environmental links to the origins of disease. Next. Next is Dr. Kartika Kumar. She's a senior consultant CIMAR Fertility Center Cochin since 2010 and Sri Lakshmi Polyclinic Alway since 2021. Consultant IVF specialist and embryologist and laparoscopy surgeon at CIMAR Fertility Center. University rank holder for MD Gynec in 2010. Trained in embryology at ER. Trained in USAID and embryo vitrification Mumbai. Further chapter on embryo transfer and decision making in infertility textbook. Faculty at national and state conferences, and her field of interest is low cost IVF, USAID vitrification, PGD. Next panel member. Next is Abhi Koshi. As you all know, Abhi is a consultant in reproductive medicine and surgery, Sunrise Hospital and Associate Reproduction Center in Sunrise Hospitals in Cochin, Kerala. And graduate from Medical College of Kottayam, residency in obstetrics and gynecology at Armed Forces Medical College, Pune in the year 2004. Gold medalist from the University of Pune. Awarded the DNB in 2015. Became a member of Royal College of Obstetrics and Gynecology in 2008. Advanced training in reproductive medicine at Homerton University Hospital, London, UK. Worked as IVF specialist in 3 different hospitals, India and abroad. Published 12 articles in peer-reviewed index journals and contributed 7 chapters in different textbooks. And he is a peer reviewer to 9 international and national journals at present. Next we have
Abhishek.
Next we have Dr. Abhishek. Abhishek is a consultant and head of Department of Reproductive Medicine, Kinder Women's Hospital and Fertility Center, Cherthala. Consultant in Nila Women's and Fertility Clinic at Kadavandara, Cochin. Honorary Fellowship of Guy's and St. Thomas Hospital in London. And Fellowship Reproductive Medicine in Trippuram Institute of Reproductive Medicine, Chennai. Next. Next is Dr. Raghavendra Prasad. He is the Director of Infertility and Fetal Maternal Unit, Sunrise Hospital, Kanjur, and Executive Director in RMC IVF in Mangalore. Next. Next, we have Dr. Srutika Thakur. She is a fellowship in holder in the reproductive medicine and endoscopy, medical director, Medansh Multi-Specialist Hospital and IVF Mumbai, working as consultant of obstetrics and gynecology in Fortis, Jupiter, Hira, Mongi hospitals. Managing Council member of Maharashtra chapter of Indian Society for Assisted Reproduction, Youth Council member of MOGS since 2015, elected MOGS is Mumbai Obstetrics and Gynecology UA Lead 2020-21, fellowship training in basic, advanced and IRT from the Homerton University and the Kiel University, Germany also. Here she has won MOGS, Dr. Shantabai, a traveling fellowship for overseas training in 2014, awarded MOGS. Banuben Navadi Scholarship for overseas studies in 2015. Awarded the Best Youth Council Member awarded for 2019, 20 and 2021. Awarded the Wonder Foxin Award in the year 2019. Has contributed numerous chapters in various textbooks published and presented scientific papers. Over to Dr. Girija. I think I have introduced all of them. Over to Dr. Girija for your panel. If possible, we will use the last 10 minutes for discussion.
Yeah. So good morning, everybody. It's indeed a pleasure for being here, connecting to Kerala, one of those parts of the country which I really love, and it has a lot of fond memories in my, deep down in my soul. And I thank Tracy Louis for getting me to connect to all the experts through this particular panel today on pregnancy management after pregnancy. I think there is disturbance from somebody's computer that
Managed.
be
You
taken
continue.
care of. It would be nice. And thank you. So we can see that I'm extremely grateful to the ISAR for getting us together here for this panel discussion. And thank you, Fesi, for this. And I would like to start by being first grateful to the Almighty, by praying for all those who have suffered through the pandemic and are still recovering. And what we have to remember is that we have to live your life in such a way that you will be remembered for your kindness, compassion, fairness, character, benevolence, and a force for good who had much respect for life in general. So I think with this, I set a setting for this particular panel discussion, wherein we all know that whereas multiple gestations achieved by IVF appear to have similar outcomes to those of multiple gestations conceived spontaneously, singleton pregnancies after IVF are associated with an increased incidence of complications. And there are various reasons that have been identified. Maybe the age of the parents, there are sperm factors, there may be laboratory conditions which have been found to be implicated in finding this. So the aim of this panel today is to establish an evidence-based approach to antenatal management of singleton pregnancies conceived using ART, and little bit of things we'll be speaking also about the twin pregnancy. Now, what are the commonest challenges that we encounter? So if I can have Dr. Bhavin giving us an overview of what does he usually see. Now, we are going to divide all these challenges between the challenges which will be in the early part of the pregnancy, the maternal challenges, the fetal challenges, and the placental challenges. And then the last one will be concluding by looking at the lactation issues in these patients. So Dr. Bhavin, what would you say would be the challenges that we will have in the early part? You know, a woman has become pregnant under your eminent care. She has conceived, and I think that's one of the biggest moments for any ART specialist. How many ever patients he does. Every woman who conceives is a wonder. You know, we are really, really grateful. But then we are worried. So in the early part of pregnancy, what are the things that you think are more challenging?
Good morning to all entire organizing team, and thank you for the invitation. At the beginning, I would say getting her into a pregnancy after an embryo transfer is most crucial, and the biggest challenge, first challenge is a pregnancy loss. She could have a pregnancy loss like 6 weeks, 8 weeks, or even at 10 weeks. Yeah. So the progesterogenic effect, everything has to be very crucial, and she's always sensitive that she could have a pregnancy loss anytime in the first 2.5 months. That is one major problem. Second major problem is some medical disorders could even rise, like she could be having a pre-existing polycystic ovaries, or some diabetes could come up. It could even be an hypertensive disorder or a thyroid disorder.
Yeah, at this point we'll focus on the early pregnancy, and then we'll gradually move on. Yeah.
Also, early pregnancy loss is the most crucial event, which is a challenging. Ovarian hyperstimulation, no, I wouldn't see, because now we are more into planned frozen embryo transfer. We aren't doing fresh embryo transfer. So the earlier there was a challenge with late ovarian hyperstimulation syndrome, yes. Ectopic pregnancy is another important challenge that we can face. And the patient always asks us, how come it became an ectopic? Yeah. So these are the few challenges in the early pregnancy loss, that is in the first 12 weeks of pregnancy.
Absolutely. So that was a wonderful question. And as you very rightly said, that all with the expertise and so much evolution in the ART practices today, this particular thing as a OHSS has been actually a negligible practice. But I must share with you, Dr. Bhavin, that we are also catering to a critical care unit in my university hospital. And we do have at least once in 6 months a patient getting hospitalized in early part of pregnancy with symptoms of OHSS. So despite trying all these kind of measures, sometimes you do have, and we have to be very, very on guard looking at these patients, especially in the first part of a pregnancy. And as you agreed, that it would be a very commonality. Now, coming to Karthika, vaginal bleeding is one very big challenge that we face. And as Dr. Bhavin said, that miscarriages are quite common. And you saw the incidents, the screenshots which I had put in the slide. These are all based on whatever has been the studies done over a lot of patients, because we all understand that there's a lot of data from Belgium, because Belgium keeps all its ART records very well with long-term outcomes of IVF pregnancies. And whatever screenshot I had put in were the incidences. I'll go back to that because that's something that we all should understand. And they've given a very wonderful kind of a recommendation. So OHS, as you said, is negligible. Miscarriages, women should have access to specialist counselor before, during, and after ART. That can be a tragedy. And of course, ectopic pregnancy, the recommendation is you have to manage it as it would be in any other pregnancy. So coming to you, Karthika, that whenever a patient comes to you with vaginal bleeding, what are the things that come to your mind? You know, the first thing, of course, we'll do a sonography, but what else comes to your mind, Karthika?
Good morning, ma'am. I'm audible?
Yes, very much so. Thank you so much, Karthika. Yeah.
First of all, getting pregnancy in following an IVF, it's like a dream come true for the patient. So anytime if they get a spotting or even a small spot, the patient get kind of like very panic. So they come running to you, and the first thing what we do is we do a scan. We see the location of the pregnancy, whether there is any retroplacental hematoma is something we have to see. Then basically it is counseling the patient, reassuring the patient, and most of the time it might be an implantation bleeding, or it might be an early sign of an impending abortion. So counseling and reassurance is the first thing that we have to give these patients.
Yes, because we find that most of the times who are between 10 to 20 weeks of gestation, nearly 11% of cases would have SCH even in a normal pregnancy. So in an ART, a similar kind of incidence would be there. And I think, as you rightly said, we have to counsel this patient. And it is not the retroplacental at this point in time in the early part of pregnancy. It would be usually a subchorionic hemorrhage. I think, yeah, it was a little, we are busy answering the question and then we get confused with these terms, but SCH or SC hematoma, that's what we call it. And it would appear due to partial detachment and chorion membranes. And this can be usually seen in patients who have something which has happened, or maybe a past history of recurrent pregnancy. And as Dr. Bhavin and Karthika have been saying, a lot of anxiety comes into being. Have you ever, Dr. Abby, hello, I think Dr. Abby is connected with us today. Yeah, Dr. Abby?
Yes. Yes, ma'am.
Do you think that it can be a pelvic infection, especially the cervicitis, vaginitis, because, you know, we are giving them so many medicines, and can that be the cause why she would have this early pregnancy bleeding?
What we see is that a lot of people who conceive after fertility treatment are very over anxious, and they are observing each and every sign and symptom which might indicate that something is wrong. And even a change in the color of discharge or a spot of bleed is something which is picked up by a post-ART pregnancy, but not by a regular person, because they are not that concerned.
Yeah.
So whenever we use vaginal medicine, some people, especially if they're on long-term medicines, do sometimes have a bit of dark discharge and sometimes a bit of vaginitis. Per se, pelvic infection where the upper pelvis is involved after a treatment is quite uncommon, but the former is much common.
Yeah. Have you, in a routine practice now, since all of you seem to be IVF specialists, I'm actually tempted to ask you this question. Should we ideally be doing a vaginal, infection screening before we embark upon embryo transfer? would it reduce all these problems like preterm delivery? We are going to come back to preterm delivery also. Bhavin is trying to raise his hand. Yes, Dr. Bhavin, I want you to answer this.
There is a definite literature evidence embarking on the vaginal microbiome. That is, the vaginal flora definitely makes a difference prior to the embryo transfer and even throughout the pregnancy. So maintaining it on a particular period of time is important, but we also have to emphasize to the couple maintaining the hygiene and also through the diet that she maintains. Prebiotics and probiotics should be included in the diet so as to reduce the chances of infection. And the most common challenge that we face in an IVF pregnancy after 12 weeks is 16 to 18 weeks, she comes with a cervical ballooning. And most often it is always an infective etiology. And that could be either a local pathology or a infective, that is a gut. The gut is the most important thing.
We are going to revisit this problem once again, Dr. Bhavin, because I really believe in the same kind of a thought process and principle. Now let's come to Shrutika. I can see her peeking from the topmost window on my screen here. Consequences of subchorionic hemorrhage. As we had Dr. Karthika telling us that it can be a possibility of an early sign of abortion. But are there any other possibilities also? Because if you look at the evidence in literature, it doesn't say so. But then there are some meta-analysis which are supporting while some other aren't. Yes, Shrutika.
So the first thing that happens, and I think all the panelists have also agreed, is that ART pregnancies are associated with a lot of anxiety in the mother's mind. And the most thing that happens is a panic reaction and a lot of increase in anxiety and psychological stress regarding a loss. There is definitely an increased risk of early pregnancy loss. Most commonly, I raised my hand to just answer the previous question also, that there can be associated infections because of the use of vaginal progesterones, gels, as well as capsules. And good hygiene of the patient is extremely important. So maybe doing a high vaginal swab when there is evidence of infection, when there is altered color discharge. A lot of patients misunderstand the vaginal gel coming out with a foul smelling discharge, and then they'll end up with a subchorionic hematoma. So getting a good urine routine as soon as the patient conceives or at the first sign of trouble would be a good practice. I don't think that there is an increased risk of complications in the third trimester in the form of preterm labor or abruptio placenta associated with a subchorionic hematoma. So I feel that if it is controlled adequately, other than the fact that it is associated with the first trimester loss, there is nothing much long term.
All the same, I would agree to most of the things that you're saying because the evidence doesn't support. But all the same, whenever you have a subchorionic hemorrhage, we would want to keep on looking at this patient a little regularly. Every time that she has an opportunity of doing a scan, making a note of that so that we see whether she's having any placental abnormality or else, would be a good practice. It doesn't mean, because these people are also at risk of having morbidly adherent placenta and issues like that, especially if they've undergone some intrauterine surgeries before their conception, because most of the times we choose IVF in our country when everything else has failed. And that is the time where they would be at risk of these things. And what would be the treatment for this, Dr. Abhishek? What would be the treatment for subchorionic hemorrhage? A patient is present you with HCH. Yeah.
Hello, good morning. I hope I'm audible.
Yeah.
So most of the time, subchorionic hemorrhage is not really associated with any cause. It's idiopathic in most of the cases. And after IVF or after an embryo transfer, we actually give a good amount of progesterones. Generally, we just continue the same amount of progesterones. No extra progesterones is generally required. And even fibrinolytics like tranexamic acid aren't generally required. I think reassuring the patient and advising rest is the way to go.
Okay. What about progesterone, HCG injections, tranexamic acid? Because these are seen in the prescriptions many a times of the doctor. Out of
that's right.
Mostly, maybe, yeah.
That's right. So already these patients are taking progesterone. Probably they're taking synthetic progesterones or micronized progesterones. And most of the time, the subchorionic hemorrhage is not a cause of reduced progesterone levels. Mm-hmm. So they can just be continued at the same dosage generally. again, giving HCG injections on a weekly basis, there's no evidence to say that there will be an improved outcome for this.
Okay, but then the patient feels nice when she's pricked and she's being.
To be honest, we do give an extra dose of an injection, but I would say it's to mainly reassure the patient so that they have a feeling that we're giving something.
Correct.
But whether it really gives any extra benefit,
We do not know. And what about tranexamic acid? Yeah, Shrutika is raising her hands. Shrutika, you want to say something about this?
Girja ma'am, want to give you the practical thing that most people end up doing. I mean, although whatever we say about guidelines and all, most people, depending upon how much bleeding is there, how big the hematoma is, would like to give a small course of antibiotics, because there is some incidence of the hematoma getting infected if left alone. There is some benefit of giving HCG injections in terms of immunomodulation. HCG is known to be an immunomodulator, and usually weekly 5,000 IU intramuscular injections are given to the patient by most gynecologists. Tranexamic acid is, there are no adequate studies regarding safety, but I think by experience, most of us have used tranexamic acid in such scenarios to limit the bleeding. And I think 500 milligram TDS, most of us have used, and it doesn't cause any harm. The studies are equivocal about the benefit of tranexamic acid. Extrapolating the data about low serum progesterone being associated with first trimester losses, I think doing serum progesterone levels at this point of time, if not for anything else, but just to check the patient's compliance, would make sense. And if it is less than 15, supplementing it with intramuscular progesterone might be also useful.
Yeah, so unfortunately, all these things require a lot of evidence backup, and therefore people like us, especially I can see 6 very, very eminent and accomplished IVF specialists here. We all should compile our data and analyze this, because world over today, there's a lot of movement going in the Western world, trying to be as minimalistic as possible during the first trimester, especially because of want of possibilities of some abnormalities in the babies, which we have not been able to find out till now. And that is the reason why we have to be, but yes, we usually all of us use these practices, and we have not seen any obvious harm, nor we do not know whether it has helped either. Second question, the last question on this particular issue, I would like to ask Dr. Raghavendra. And Dr. Raghavendra, if you have already started your patient on low dose aspirin or she's on heparin, are you going to withdraw that if the patient has a subchorionic hemorrhage or a hematoma?
I was about to ask the same question that side, because basically most of us, I mean 50% of the IVF specialists would be putting the patient on aspirin or heparin. So the ideal thing would be, theoretically, if you look at it, to stop the injections temporarily if the patient has seen bleeding. But when we ask the medical experts, they say the amount of dose which we give, that is the 20 units of heparin and 75 milligram of ecosprin, is very less, that even if you do not stop it, normally nothing happens. But from our point of view, I would prefer to stop the drug for at least a few days till the hematoma is completely subsided.
And the question remains unanswered, whether this hematoma is a result of the blood thinners also that we are giving. So
yeah, that
can also be a possibility. But yes, that confusion still is there. But I think I thought I must get this across, because most of us would agree that these are the practices that we do in the actual practice. Now coming to the
one point.
Yes,
actually, we all gynecologists have to realize, when we see a medical assisted reproductive technique, we are seeing an embryo transfer without a corpus luteum. So the corpus luteum absent is the basic reason that we are seeing the problems for the first 8 weeks, and also for the late pregnancy, that is after 28 weeks of gestation. The lack of corpus luteum causes lack of cytokines, and lack of cytokines causes entire problems to base. So all this is related to the absence of corpus luteum. So we have to really understand that supplementing HCG and not more than toxic doses of progesterone. It should not be. We give dufastone, we give progesterone, we give different doses. It should not be a toxic level. That can also cause a damage.
So I think you have made a very wonderful point that we are looking at an artificial reproductive technology, which is a lot of things in this are artificial or maybe assisted, let's call it, that is the better word. That means we will have to be a little proactive whenever we are giving prenatal care to this patient, and maybe being very minimalistic may not be really ideal. And especially looking at our country, where we already, even in a normal population, have a very high incidence of spontaneous miscarriages and preterm deliveries. All these things which we may call as an overly added interventions would probably be justified in these patients. Now, I have decided to come to the progesterone story. And for all these while, we have been only talking about progesterone in the context of whatever its functions happened in our natural existence, in our natural body. And whenever we decided to speak about the synthetic supplementation of progesterone externally for various reasons that we have been talking right now, we have found that the evidence doesn't really support much of these acts. But today, we are much justified, and I think I decided to put up this slide especially so that we can derive some confidence to the fact that the PROMISE and the PRISM studies which have come over now have given us some sort of credentials in using the progesterone that we are using. Now, since Dr. Kedar was the one who communicated with me about this particular panel, we wanted to come to some sort of a consensus and understanding in the next 2 minutes. We are not going to spend more time on this. Is what would you suggest to be the right dose of vaginal progesterone through your experiences? Anybody on the panel can take it, and there can be a second person who would want to say something, if at all. So
to begin with, like when we look at the oral micronized progesterone, the 200 mg of micronized progesterone will equate to dydrogesterone of 10 mg, which is equivalent to 25 micrograms of subcutaneous progesterone. So this should be the minimum, and we cannot go beyond 30 mg per day. So that will be approximately 600 mg of micronized progesterone, or even 25 micrograms of subcutaneous progesterone into 3. Beyond which, we have to give it only when a crisis arises, and we need to change our molecule in case it is an intolerance to the couple. That we need to understand.
Absolutely. So that was a wonderful calculation and a formula you gave us objectively to make it easy for us to understand. Unfortunately, because there is no clear-cut guidance or evidence of easy on this. Now, I had Dr. Abi raising his hands. What would you want to tell me about combination? You know, sometimes we use the dydrogesterone, and we also use the natural micronized progesterone, and we also give a gel sometimes. What is your take on this, Dr. Abi, or anybody in the panel would like to talk about this? Because I'm sure our viewers must be having these questions in their minds. And I am not only the moderator of this panel, but I'm also on the side of the viewers.
Well, the reason I had raised my hand was again because for the aspirin thing, because there is good data to show that aspirin increases first trimester bleeding. Okay. And also regarding the PROMISE and PRISM trial, this is regarding only recurrent pregnancy loss, not in the context of ART. Yeah. Now, coming to a question, I worked in the UK for a substantial time where there was no mixing up of too many progesterones. You just give one progesterone and that's it. Okay. And the results there and what we see in India is more or less the same. So it's probably a misconception that we need to pump our patients with progesterone. The second concern most Indian doctors have is that if we are giving a dosage of progesterone which is to be taken vaginally, the patient might not be using it properly. That is why you need to add more progesterone by either a parenteral or an oral method. I think this is something which is very, very debatable, and you should have an opportunity to discuss with your patient regarding all these things before prescribing all these things. Unfortunately, we are seeing patients with a prescription which is like what we see for our COVID patients, 15, 16 medicines. We don't need that. I still have a prescription which is just 2 or 3 medicines, folic acid, progesterone, and maybe something else if it's needed. That's all. And it works quite well. I think that's fine, good enough.
Okay, so therefore we have to be a little guarded on this. What about the weight of the patient? Does the weight of the patient determine the dose of progesterone?
Again, I would not add to that. Most patients are okay with a standard dose. It doesn't make much of a difference from my practice and my experience and the data I have from reading about progesterones.
So both our panelists are actually speaking on what is present and published in the data. So we have to be properly balanced, identifying, and mostly I think the result of this long prescriptions is also a reflection of the anxiety of the treating physician. And there has been this Cochrane review, progesterones for preventing miscarriage, a network meta-analysis. And what it mentioned is that there's still uncertainty over the effectiveness and safety of alternative progesterone treatments for threatened and recurrent miscarriages. So this is what we are still standing at. And now you could have your patient coming to you with this kind of a sonography report, or maybe she would just report to you in a catastrophic situation. Now, in this particular picture, you are seeing that this is a cornual pregnancy, a heterotopic pregnancy, along with an intrauterine pregnancy. Now, what can be the approach to this particular situation? Anybody, Kartika, you would want to answer this question? Dr. Raghavendra is not seen on my screen, I'm sorry. Dr. Raghavendra, can I have you here?
Yes.
Yeah. So you have sonography, and this is the report. And you can see that this is a heterotropic pregnancy, and she's reported now. So here on the other side of the screen, you're seeing that it's come presented as a ruptured ectopic. So there we have for the mother. But if you have a sonography picture, as you can see on the right of the screen, where you have just done a diagnosis, what should be done?
Now, if it is a cornual ectopic, probably the only thing what optional left is for us to go in for a laparoscopy.
Yeah.
Anyway, try to conserve the intrauterine pregnancy. I would just drain the cornual pregnancy and put a stitch and leave it there.
Yeah.
I would try not to do as much, a lot of interference, because I would try to conserve the intrauterine as much as possible.
Yeah.
So if it's a cornual pregnancy, again, drainage of the cornual pregnancy and just put a stitch so that she doesn't bleed in that area.
Mm-hmm.
If it's an ectopic, proper ectopic, you can proceed with a salpingectomy if required.
Okay. But definitely we would want to stop the bleeding there. But if she wouldn't be bleeding, still we will have a laparoscopic access for the cornual pregnancy?
Cornual pregnancy, definitely, madam, because cornual pregnancy is always a risk. You have to go in for a laparoscopy because it will create problems, because you have an intrauterine pregnancy also which is growing.
Yeah. What about, can we tackle it with some glue or something? Everybody in the panel has a sort of experience using a glue at the cornual pregnancy for obliterating it rather than going in for stitching and coagulation? I think so. Yeah, we do not have so much access to these things, but there are some few studies where people have used injectable glues while doing a laparoscopy for a cornual pregnancy which is not ruptured. And you can see a picture at the time of a C-section where the cornual site of the previous pregnancy is seen very much at the time of a cesarean section. So yes, we have to be on guard, and then there are certain issues here. So can Dr. Shrutika tell us as to when we are monitoring our patient from the time that we have done the embryo transfer till the time we establish that it is a successfully clinically confirmed sonographic intrauterine pregnancy? What are the various things that we should monitor and try to look for so that we are sure that this is not an ectopic pregnancy? Dr. Shrutika, please.
Yeah, thank you, ma'am. The first thing is we always need to be watchful about the possibility of an ectopic as well as a heterotopic pregnancy whenever any ART treatment has been done for the patient. The first checkpoint is definitely the beta HCG. When we get the first beta HCG, I think it is common practice that we repeat the beta HCG again in 48 hours to check for doubling. If the doubling is not adequate, then you are even more on guard regarding the possibility of a ectopic pregnancy. Somewhere around 1,000-1,500 IU, we would do a vaginal ultrasound to kind of see whether there is a GSAC also in the adnexa. I wanted to mention something about the heterotopic pregnancy question. We also are doing ultrasound guided aspirations of the heterotopic sac, provided the patient is hemodynamically stable and definitely not for a cornual site, but if it is in the tubal part, I have had good results with just aspiration of the sac. you have to make sure that the patient is hemodynamically stable and it is not a live pregnancy that is growing in the ectopic site, and the beta HCG levels are less than 3000. In such cases, we can go ahead and aspirate the sac as well.
Okay. So what is very important message that we have to understand is that we have to be on guard, that there is always, as Dr. Bhavin at the very opening time had mentioned, that there is an increased possibility of an ectopic pregnancy, and we have to be on guard about that. So that was about the first trimester. And then we come to the second section of maternal complications. Dr. Karthika, what are the various maternal complications you feel you have encountered? And we always feel that our ART patients are going to have these problems a little more. While if you look at this, again, I have put in a screenshot of one of the studies, which is mentioning that we have to do, pre-eclampsia induced or eclampsia ART is not an indication for prophylaxis in the absence of risk factors, is what is the as per local and national guidelines. In the UK, ART is not an indication for glucose tolerance test in the absence of other risk factors, while you'll agree to me that it will be different in the Indian setting for various reasons, which we are going to discuss shortly, and of course, the venous thromboembolism. So if you have a patient, have you experienced, Karthika, that pre-eclampsia, eclampsia, or early onset preeclamptic toxemia is a little more in your patients? What is your call on this? What is your experience? I think you need to unmute yourself, Dr. Karthika. We missed your 2-3 sentences or words. What do you say?
Yeah, I'm sorry. Most of our patients who are undergoing IVF already aspirin dose. We do a preeclampsia screening at around 11 to 14 weeks with the uterine artery Doppler and the mean arterial pressure. So, and the PAPA, if the PAPA is low and if the screen positive is coming, then we actually increase the dose of aspirin to 150 milligram. So the incidence of this severe preeclampsia is very rare in our group of patients. And because of the serial monitoring, I feel like now the incidence of eclampsia has come down drastically.
Yeah, it's come down drastically because we've become vigilant, but I must say
vigilant
that it is much rise on the periphery. Like in the naturally occurring pregnancies, we still have a high incidence of preeclampsia. Maybe all the patients that are going through ART are very well properly under surveillance, and therefore these screenings are there. So do you specially consider doing the screening surveillance for preeclampsia as is recommended in the current situation, like doing blood pressure, mean arterial pressure, proteinuria screens, biochemical tests, and biomarkers? You mentioned the uterine artery PI. So do you?
Yes, we do a screening at around 11 to 14 weeks along with the NT scanning. And if the PAPA is low, or if and the screen positive is there, actually we increase the dose of aspirin at that time itself. And then people will be in close monitoring in their pregnancies later on also.
Okay, coming to Dr. Abhi, would you recommend doing a proteinuria screen for all these patients, even if their blood pressure is normal at around 12 weeks?
I would not be saying it's a very routine thing in my practice, and so I would not be recommending it, but definitely we do look at uterine artery PI and the biochemical markers, and obviously the background risk factors like age and previous history. Yeah. Unfortunately, we are seeing a very, very low incidence of preeclampsia compared to say 5 or 10 years back.
Yeah.
I would not say the same with gestational diabetes. It's double and triple in the same duration.
But preeclampsia, yes, because if you remember a long time back, there were quite a few studies from the NHFS survey saying that if there is a proper antenatal care given to the mother, we can definitely reduce preeclampsia and eclampsia incidences. And I think all the IVF ART pregnancies are an evidence to support this, but there are going to be certain challenges. What is very important is, even if you have a patient and a lower incidence, the reason why you have a low incidence of these occurrences, probably you're screening your patients very well by doing the correct blood pressure monitoring at the right time and a regular interval, and also looking at the mean arterial pressure. And today, a lot of things are being spoken from the fetal medicine group, wherein they have done a study on a large quantum of patients where they feel that doing a mean arterial pressure, especially when you do not have the mercury manometers in your practices, is a good practice. And you can use this fetal medicine software, which is freely available on the net, to identify or determine the risk of preeclampsia. I was talking about the protein creatinine ratio, while in my practice, probably I'm a little more partial towards preeclampsia, HDP, and sensitive to these disorders. Usually at around 12 to 16 weeks time, whenever I get an opportunity, I do a protein creatinine ratio, as Dr. Abi mentioned, in those patients who are having a background risk of preeclampsia. Because while we are looking at the uterine artery PI, that's a very important event, but also looking at the maternal proteinuria also helps in identifying those, or maybe tagging those patients who probably have a possibility. And what we can do is we can just do a protein creatinine ratio, and that if it is found to be more than 30 milligrams per millimoles, tells us about proteinuria in its early placement. Now, while we were talking about the screening and evaluation, there is this recent guideline which has come up in both the, a lot of ISSSP and all these people, ACOG practice bulletin together, mention about taking blood pressure correctly. They speak about screening for hemoglobin, platelets, serum creatinine, liver function tests, especially in patients where you find that the blood pressure is 140/90 or more. And then serum uric acid also has been included once again, which was not there in the previous part of the practice. Coagulation profile if there is thrombocytopenia. LDH has been recommended by the ACOG because they want to look at the hemolysis, and there has to be an ongoing surveillance for preeclampsia, which involves repeating these tests weekly or twice weekly, depending on what is the patient's condition. So there are a lot of biomarkers mentioned in these women who probably now, as Dr. Abi said, we do a risk assessment in these patients, and if there are all the risk factors which are pointing to preeclampsia. Dr. Bhavin, would you recommend doing biomarkers in the first trimester, in the second trimester, to these specially clinically tagged patients? What would be your opinion?
Yes, thank you, ma'am. Routinely screening at 11 to 14 weeks with an ultrasound that is looking at the NT scan, and also asking for a PI screening that is for preeclampsia screening protocol is only the one which I follow. And based on whether they have gone through a donor embryo program or a donor ovum program, that will also make a big difference in my screening protocol. There are again a double marker, and there is a non-invasive prenatal testing is also suggested to the couple. Based on that decision, they can go ahead. So pre-test counseling is definitely a must, but not on every person. I don't go for all this biochemical markers, no.
Yeah. So there has been a lot of material now available, wherein they mention that we can do the PLGF along with the double marker, the combined testing that you mentioned. And for an ongoing screening and surveillance in the second and third trimester, we can consider either the PLGF or PLGF S-plate ratio and glycosylated fibronectin. What I feel is once the patient has really developed preeclampsia, that would be the time for maybe risk stratification. We may consider doing this. But otherwise, universally, just because we have a patient of ART, we wouldn't consider doing it. Of course, there will be a little different approach, as Dr. Bhavin rightly said, if the patient has clinically. So how would you interpret this, Dr. Shrutika, if you can tell us, like what kind of uterine artery PI, and can you just explain to us what is this uterine artery pulsatility index, which we do at NT scan? What would be a timing in the gestational age and the interpretation?
So generally, we do the uterine artery PI along with the NT scan. There are a lot of radiologists who are now calling it as the fourth marker that they are doing along with the NT, the nasal bone detection and all. So the pulsatility index is basically assessing the resistance with which the blood flow is going. PI is typically the measurement of the systolic peak upon the diastolic peak, upon the difference in the diastolic peak. So it is basically telling us at what resistance the blood flow is going in the right uterine artery as well as the left uterine artery. Generally, there is a mean PI of the right as well as the left uterine artery, which is calculated. And if the PI is above the 95th percentile, that means roughly if it is around more than 2 or 2.5, then there is a risk which is mentioned by the radiologist, which says high risk for preeclampsia. And that is when we need to intervene.
Yeah, so we have a little bit of, toned it down to say that 2.37 average would be the one where we'll pay attention. The reason of taking an average would be the fact that there can be placental laterality, which can influence the measurement of this pulsatility index. And that is the reason and the rationale given behind that. And what I wanted to depict through this picture is, yes, preeclampsia is a placental disease. And you can very well appreciate in this picture here that there is definitely a reduction in the diastole. And if you find this, and therefore, as our IVF experts and expert panelists are mentioning, uterine artery PI gives them a lot of insight early on in pregnancy, wherein they can modify their approach to the patient and then be on guard for looking for preeclampsia. And these are the various uterine artery PI cutoff values in the first trimester, as Dr. Shrutika very rightly said. Rather than 2.5, you choose 2. If it's a transabdominal scan, then 2.35. It's a transvaginal 3.10. Second trimester, mean PI at 95th centile at 23 weeks, 1.44 for transabdominal and 1.58 at transvaginal. And third trimester, mean PI 95th centile at 30 to 34 weeks and 1.17 at the transabdominal screening. And then we have spoken, both our panelists here, Dr. Abby and Dr. Bhavin said, that we are looking at the history-based screening for preeclampsia, as the NICE has been talking about. You know, there are various high-risk factors like hypertension, chronic kidney disease, autoimmune disorders, diabetes, chronic hypertension, age of the mother, her obesity and family history, multiple pregnancy, etc. The ACOG has gone ahead and it has also added more maternal factors, including assisted reproductive technology, also as one of the risk factors. So while we are talking about this, I would take this opportunity of introducing to you the Hypertensive Disorders in Pregnancy Justice Score India, wherein we came with this particular very simple scoring for our Asian ethnicity, because there are a lot of factors, as somebody was just now mentioning, that if the patient has PCOD or something, there are large possibilities of having issues. Plus, we have women who are getting pregnant at a very young age, and we know that preeclampsia is quite common in early younger women. Of course, this will not hold true in an assisted reproductive technology, but all the same. So age more than 35, less than 19, maternal anemia, BMI more than 30, primi gravida, short duration of sperm exposure, women born at SGA, family history of cardiovascular disease, maternal hypothyroidism, PCOS, interpregnancy interval more than 7 years, IVF ICSI pregnancy, MAP more than 85, chronic vascular disease and excessive weight gain during pregnancy. These all have been awarded a score of 1. And along with that, we have also given weightage for GDM because it's an ongoing surveillance, a score of 2, obesity, more than BMI more than 42, multiple pregnancy 2, hypertension in previous pregnancy 2. And if you look at the risk factors, and Bhavin here is an sort of an, kind of an evidence or support to what you've been saying, that pregnancy with ART, especially oocyte donation surrogacy, would be awarded a score of 3 because they are much at risk of developing preeclampsia, especially early onset preeclampsia. And then, of course, the rest of the ones which are obvious, like we know autoimmune disease, chronic renal disease, chronic hypertension, all these women would be at risk of developing preeclampsia. And therefore, this is a typical historical score which you can just offer to your patient at the time when you're establishing her pregnancy in the first trimester itself. And then as you're doing the ongoing surveillance, looking at her MAP or the development of GDM or weight gain, all these will be ongoing surveillance. What we observed is this awards differentiated scores to each character, is feasible in Indian setup to work out, and is based on history and MAP, cost effective. And if the woman has a score of more than 3, she has to be tagged and then given a proper surveillance so that you do not have to do universal screening to all the women, so that we can have a little resource sort of a conservation. Dr. Bhavin has raised his hand. Yes.
I think, Madam, this is a very interesting slide, which actually emphasizes historically and evolution-wise, each of us ethnically are prone for metabolic diseases. So we should be all, I think, put on a high risk for hypertension, diabetes, because if you look at the data, I think each and every patient will fall into this category. Mental disorders, something or the other is happening.
And we have to be therefore on guard. And I think this is a very simple score. You can just paste it and give it to your nursing staff also. They can just tick mark it for you, and you can understand issues and maybe educate your patients, because I feel not that is happening in future. We are right now seeing, we have women who are coming at the age of 40 and 50 with IHD. Right now at this point, my own sister-in-law has been hospitalized with post-hypertensive stroke at the age of 38. And these things are happening, and these are very, very common, that younger women are getting affected, and we have to be on guard. And then, of course, we've been talking about doing the screening in the first trimester, and the FMF calculator is there. And of course, we are swinging our pendulum between the 75 and the 150 milligram aspirin. And I think there is a lot of evidence which is now supporting that in all those women who are high risk, we must give them 150 milligram of aspirin. While if you look at the American and the Canadian guidelines, they will be talking about 162 or 81, because their FDA doesn't approve manufacturing of 75 or 150 milligrams of aspirin. That's the reason why they would keep on talking about 81 and 162. While in our country, as Dr. Karthika said, we'll probably do the stitching. What is very important that we have to remember that all categories of hypertension in pregnancy, even if the patient is chronically hypertensive, are at risk of going into an preeclampsia. And therefore, an ongoing surveillance is important, looking for clinical issues, and then, of course, looking at the triaging. What would be your take on your patients? Any of you can take this, because most of high-risk mothers are undertaken for assisted reproductive technology treatments. And therefore, whenever they have an additional sort of a pressure of pregnancy, they are at risk of a lot of cardiovascular issues. So do you routinely practice doing a maternal echo for her cardiovascular assessment? If yes, when? During the course of pregnancy? Anybody can answer this question?
Actually, the time of that is the time of OPU. Oocyte pickup, the anesthetist has already done a screening. And my recommendation is, if the anesthetist or the medical physician recommends that she needs to undergo an echocardiography, she goes for it. Second, I also include certain features like Marfanoid, which is going to give me a clue that we should do an echocardiography or even screening protocol. And definitely ladies with advanced age, that is maternal age more than 40, that is routine.
Okay. Anybody else would like to comment on this?
Yeah, basically, madam, in our protocol, it's almost similar, because any patient who is going in for an home pickup anyway invariably gets an echo done from the physician medical point of view. Plus, any patient like who is going in for donor embryo, because we do not basically evaluate the medical status of the donor in terms of the cardiac status. So basically, right now we have started evaluating them also thoroughly in view of echo and all those things before we plan a transfer for that. And once, if it's an asymptomatic pregnancy with no history of PAH or anything, there is no other medical intervention done other than we using ourselves to auscultate. But if the patient is having PAH, definitely at the beginning of the third trimester, we do take a medical opinion, and the physician does an echo to be on the safer side, I would say, even though it may not be in the category of severe preeclampsia or otherwise.
Okay.
Ma'am, in addition to this, I would like to add that we should I agree with all my panelists about a pre-ART evaluation, which has to be thorough. But definitely a person who has developed preeclampsia or has severe hypertension in the third trimester, we should do a echocardiography between 34 to 36 weeks, and also after delivery. Also after delivery, there is an increased association with dilated cardiomyopathy. So maybe at 2 to 4 weeks post-delivery, reference to a physician and follow-up echocardiography is recommended.
Dr. Abhi is raising his hand. Yes, I would want your opinion, sir.
I beg to disagree with most of the panelists here, because what I feel is that though a test like an echo might pick up a rare case, I would not consider it as a standard of care. In patients who are at risk, suppose, especially like as an ART practitioner, we might see a woman with Turner or Mosaic Turner who might need ART. We definitely need to do an echograph, or somebody who is having a background risk or a background medical problem. But just because a test is available, especially in an urban setting, doesn't mean that it should be a standard of care for all ART patients or all patients who are going for egg collection. I think that's an overkill.
Fine. So we have to also look at the balance as to what is available, because sometimes I understand that we would want to do the best what is accessible. So maybe Yes, if you feel, and I would also, sitting in the city of Pune, would recommend, especially for all those obese women who are diabetic, chronic hypertensive, to undergo echo, as Dr. Shrutika said, would be between 34 to 36 weeks, because I wouldn't want any surprises. But agreed that it is not a universal ROM. But yes, Abby, I would like to add, which I have not put in here on the slide, please use screening for anemia as a universal norm before doing an ART, because many a times we still have patients, they have undergone an artificial reproductive, assisted reproductive technique, they have gone an embryo transfer. After they become pregnant, they come to us and they are having a hemoglobin of 8, 9. I think this is not acceptable. So therefore, we have to look at generalized health, maybe not something very hi-fi as a 2D echo, maybe, because today we are seeing, however, that even a echo has become very, very easily available, far reached out in various parts of our country, and that shouldn't be a challenge. I think we'll not spend more time on fetal surveillance, which obviously if the patient is at risk, we are going to do that as and how. We will come to another disorder that is very important, and Dr. Abby mentioned that what we are finding, and I'm sure this must be because especially in the southern part of our country, there's a very, very high incidence of diabetes during pregnancy, especially GDM, to the tune on the today's national average of incidence during pregnancy is about 29%, because probably we are doing more screening. So what would be the sort of a protocol that any one of you would follow? You could just take this question, because many a times we consider doing screening for GDM only in the second part of pregnancy because we are looking for gestational diabetes. But in our country, even the government of India mentions that the screening has to be done in the first trimester itself. And now you have patients where you have planned a pregnancy and then you are taking her forth. So you already have an opportunity of doing a proper preconceptional screening or what. So what is your practice as far as diabetes during pregnancy or in context is concerned? Who would want to answer this? This is free. Yeah.
Yes, Shrutika.
Yeah.
No, so universally, I would screen at the first booking as soon as, and these ART patients are already with us, so we would have evaluated sugars pre-ART as well. Also, I would repeat at least a fasting blood sugar and a HbA1c in the first trimester. Following which, if there is no risk of diabetes, I would do a repeat oral glucose tolerance test at 24 to 26 weeks. So that is the protocol that I am following. Different people have different, some people follow the DIPSI guideline, which is a single test that can be administered in the OPD, and others do the full OGTT. That is up to you for interpretation, but I feel that these two checkpoints are absolutely essential in the first trimester as well as at 24 to 26 weeks.
Absolutely. So we have to be paying credence to the fact that we have an Asian ethnicity where we have inherently very high insulin resistance. You rightly put in, okay, fine, if you don't want to practice, because DIPSI has been typically mentioned for all those patients who have conceived normally. It doesn't specifically talk about ART or anything of that sort. But especially in our patients who have an opportunity of preconceptional optimization, I think it would be a good practice to determine hyperglycemia or hyperinsulinemia in any form, so that it would cause not cause a challenge. Of course, I can have a little kind of an opinion. Bhavin is raising his hand.
Yes.
As what would be your practice? Would it be a DIPSI or?
Madam, we are all, our diet base is purely carbohydrate, simple or complex carbohydrate. And I don't emphasize the family or the couple to change the carbohydrate except for, reducing the refined carbohydrate diet. But I emphasize them, yes, you have to do a weekly or every 10 days home glucose monitoring with a simple, effective glucometer at home. Explain to them what is fasting, what is post-meal 1 hour, that is three times in a day, and that is enough to inform us whether we are going beyond a border. So home glucose monitoring will pick up those things, those patients which we miss between 1 month to the other month. Absolutely. And that is how we can effectively screen and randomize.
Anybody else wants to add? Yes, Dr. Abby.
What I would like to emphasize, other than the testing part, is that many of our patients have a tendency to consider ART pregnancies as 9 months of rest without any physical activity, and that definitely increases their risk. Also, we have a subset of patients with polycystic ovaries, which by themselves have a high risk for diabetes. So whenever we see such patients, in the first trimester itself, we try to educate them. We make them see a dietitian if needed. to emphasize that you have to make sure that not getting pregnant is not enough. You have to make your pregnancy uncomplicated. And for that, you need to make sure that you have adequate physical activity, gradual weight gain, and a well-monitored pregnancy.
Excellent, because I think not only is the physical activity going to help her in sort of improving the efficiency of her insulin, but there is enough evidence today to say that it also reduces a lot of other challenges like pregnancy-induced hypertension if the woman exercises, and that's what the ACOG practice bulletin also mentions. And Shrutika very nicely put forth the fact that she would like to do a glycosylated hemoglobin, maybe in the first trimester itself, which can give her an inkling. And Dr. Bhavin said that I would do a random sugar or do a home BP monitoring. Excellent, because what is very important in a message that I want to bring across is she's become pregnant, just not wait at it, continue screening them because this is a challenge that we have and we have to put them under surveillance, maybe 5 preventive measures as Dr. Abby said, but some point times where you must go and diagnose hyperglycemia in pregnancy. Of course, sometimes when we do the DIPSI testing, we feel that we are over-diagnosing the condition. But looking at the quantum of the problem, sometimes it feels it's okay. It's not a marker of diabetes, but at least we are coming to know that the insulin resistance is abnormal, and that is what is taken. There are a few models which have been attributed, and if you look at this predictive logistic model, it has some consequence associated with assisted reproductive technology. That's why I put in here. So we have to look at the significant predictors also, like maternal age, weight, height, racial origin, family history of diabetes, use of ovulation drugs, birth weight, and previous history of GDM. And largely, as Dr. Abby said, polycystic ovarian syndrome. And I would like to say Asian ethnicity is very, very important. So if you have a patient who is a diabetic, you've diagnosed her, what would be your second trimester fetal surveillance? Can Dr. Raghavendra tell us about this? I think Dr. Abhishek has not answered any of our questions, or he may be feeling that I have not invited him.
No, not at all, madam.
Okay.
So we our approach is a multidisciplinary approach, and if we identify a patient with diabetes, the first thing which we need to know is that can it be treated by diet alone? Does she need medications, or does she need insulin? So that would be the first step, and trying to bring this under control is what we would look at the first step.
Okay.
Second step would be monitoring the fetus at regular intervals. So checking for the growth of the baby to make sure, so that would be a good marker of how our sugar control has been for the patient. So whether it's within the right normograms, whether the baby is growing in the right method, it gives us all those, gives us information about that.
Okay, so we will be doing a proper fetal surveillance as would be mandated in any diabetic patient, and definitely Shrutika would want to add something, I guess. Yes, Shrutika?
Agree with the ultrasound surveillance. I also wanted to add that maybe at 32 to 34 weeks. So basically, it depends upon what you do in your practice, whether you would want the patient to go for a normal delivery or it is mandatory C-section. But I usually give the option of a normal delivery, and I encourage even ART pregnancies to go for a normal delivery. I would supplement this with 32 to 34 week Doppler screening, and also to rule out placenta accreta somewhere here to around 18 to 20 weeks to rule out any placental kind of.
Coming to the placental malformations at the end of this talk. So thank you so much. That was an addition which she gave, that she would also do a color Doppler. Would you want to evaluate the mother, knowing that she's a diabetic hypertensive? Yes, Dr. Bhavin.
Definitely evaluating the mother, that is a routine screening. One is the glucose challenge test, that is excluding diabetes, and even for renal function, thyroid function, important parameters, which is must.
So we have to not forget the mother while we are looking at all these conditions, and she has to be screened. And we will, these are just, I'm just putting in some screenshots of this is the Government of India guideline for GDM screening, and it is well in place since 2018. Do you have a challenge of VTE? I think most of the ART patients are on low molecular weight heparin. And is that the reason why venous thromboembolism is not so common during pregnancy? Or what is your experience? Anybody can take this? Kartika?
Venous thromboembolism?
Because known to be thrombogenic, yeah.
Yeah, most of our patients are already on low molecular weight heparin. So, and this venous thromboembolism, the incidence is mostly in OFSS patients and those with not controlled hyperemesis and all that stuff. But most of these patients are taken care of early and already on low molecular weight heparin. So, I have not seen a case of venous thromboembolism till now.
Antenatally, postnatally, probably. Postnatally. Okay, Karthika, you can answer this.
Actually, postnatally, after delivery, we usually, if the patient is at high risk, we are giving them heparin. Postnatally also for 5 to 7, for a week's time. Till discharge, we are continuing the heparin.
Yes. I think Dr. Abby has been talking about sedentary lifestyle. Yes, Dr. Abby, you have raised
Again, I would like to emphasize on the fact that we need to keep our patients moving and well hydrated. We stop heparin routinely for ART patients if they are on heparin at 12 weeks. And so we don't see much of heparin during the second and third trimesters. But if anybody is at risk, we definitely start, but there are very few numbers. Also, we do give heparin postnatally more aggressively. Any cesarean patient will definitely have at least a single shot, and anybody with a higher risk is encouraged to have a longer duration. No catheterizations like Foley's catheterization, ambulation should be very early, very well hydrated. You keep all the things in mind, always think, like when they say think ectopic, you should also say think DVT also in post-operative patients or postnatal patients as a routine.
Yeah. So whether you've done a C-section or not done a C-section, every woman who has delivered mandates this screening that she may have venous thromboembolism, even if she's outside an assisted reproductive technology. We have to remember this. Now, we were talking about fetal complications, and Karthika at the beginning did mention about doing screening, and usually at the 12 weeks time, they would do the entire screening to be sure about. And this is the timeline which would be used for. Any one of you, are you doing a routine NIPT screening for your mothers, despite doing the combined testing? Is that a practice? Because some of the practitioners are doing this in the country. So I just wanted to know, are you doing a routine NIPT to all your pregnant mothers? Despite doing a combined testing, or was it enough to do a combined testing? What is your call on this?
NIPT cannot be mandated for everybody. It is very selective, and it is based on the couple's decision after a detailed pre-test counseling. It should not be made as a mandatory, never.
Yeah.
You should also keep in mind that there are certain concerns regarding the quality of testing of NIPT in India, as well as the quality control being something which definitely you can discuss with your fetal medicine specialist. And they all talk about issues regarding the reporting quality also. So we don't want to unnecessarily do an expensive test and come out with red herrings where we don't know what to do also.
Absolutely.
And it is very sad to also see certain couples who have been undergone a double marker or a quadruple marker at 12 weeks from a particular center, particular doctor, and they come for third opinion, fourth opinion, saying that, doctor, I've been diagnosed trisomy 21 positive. So an effective pre-test counseling, give them the opportunity to go for it or to even to refuse it, especially in a scenario of ART pregnancy. Many of the couple will not be believing in that science. We don't want to do it. It's okay. But my point number one, very important, is please write down the couple has deferred the consent to undergo a testing, because lately 2020 we have seen a verdict which has come from a hospital in Chennai, and a remarkable achievement was given by the verdict in the Supreme Court, where they said just because the doctor has returned, the family has dissented the consent to go and undergo a triple marker or quadruple, that saved them from 2.8 CR.
Wow.
I think the verdict is very important. So we have to write down, yes, make it a point, write in your HIS, write in your documentation, yes, the family has been given pre-test counseling, but they have dissented. Enough, that is enough. That one word, one line made them say, and this is, it has come in March 21, April 21.
So very important message from Dr. Bhavin. Offer everything that you have probably for your patients, but when they refuse, you can just very nicely, cordially take a refusal consent, and that's really going to be important for your documentation, because yes, doctors at this point in time are very, very vulnerable, and at the receiving end, I have so many patients saying, doctor didn't tell me that I'm supposed to do this 12-week scan. Doctor didn't tell me to do this. So many of them, even doctors, medicos, do not even do a simple anomaly scan within the time frame that is required. and land on your doorsteps when things go wrong. So we have to be looking at this screening, and definitely the early scan, the NT scan when performed in the right timing can give us a lot of information. And this early scan will help you in also identifying many complications that have been put up across this slide in the fetal morphology. And these are very, very important so that you can guide the patients correctly and take a call on how we are going to go ahead with this pregnancy. It's very, very unfortunate sometimes when an anencephaly fetus pregnancy comes to you at 20 weeks and then you are in a quandary now what to do. And especially if it's an assisted reproductive technology, it definitely matters. We also, I would like to add to what Dr. Bhavin said is, we also have to give information to the patient that there are certain anomalies which may not be diagnosed in the first trimester, however great sonology sort of a machine you use and the technique you use, you would still miss a few and there would be some late identifications, and this message has to go across. And I think this should be a part of our counseling booklet in the antenatal care so that we do not suffer from a lot of distress. Another very important challenge is a lot of preterm deliveries that happen, and they are, that is one of the threats in our country, not only for assisted reproductive technology, but also for patients who are generally pregnant. And the commonest ones are iatrogenic. Of course, we have discussed about screening and you all have said such wonderful things that you use. But then there are patients who do land up in preterm deliveries. And we know that it is a very, very complex program. And the ACOG says that we must do a transvaginal screening at 16 weeks, because doing it before that is really of no help, because there's no lower uterine segment formed and it's very difficult to find out. So what are your practices in your clinical practice as to prevent PROM? Or, PROM is very, very devastating, or preterm deliveries, because it's not only the cervical length. It can also be so many other factors, the inflammatory markers, so many issues. How do you go about doing this assessment? And then taking a call, whether I'm going to continue giving her progesterone for a longer period of time, whether I'm going to do a cervical encephalage. What is the protocol to be followed? Yes? Who would want to take this? Abhishek?
Add to the slide, madam. Everything in the slide is very self-explanatory. That is ruling out or excluding local infection. But we are in a country where we have 33% incidence of a thyroid dysfunction. So thyroid dysfunction, one important thing is that they can have a preterm delivery at 28 to 29, and including hypothyroidism and preeclampsia. So TSH screening is very important in addition to whatever is mentioned in the slide.
Okay, excellent. Thank you so much, because thyroiditis especially is a very, very inflammatory process and can cause PROMs. Yes, anybody wants to add to this? I don't think we'll do a Nugent score, but at least doing a per speculum will give us a lot of insights. Yes? Anybody?
So I think the absolute indication for cerclage would be a previous second trimester loss.
Okay.
But to do a cerclage for all would not be the right thing to do. Screening again at 16 weeks or a previous history. The RCOG actually says that if they have a history suggestive, monitoring every 2 weekly after 16 weeks is the way to go.
Okay.
The cervical leg.
Has anybody used the Arabin cervical pessary? I think I've done mismanaged my slides a little. I'm sorry for that. Anybody has used the Arabin cervical pessary?
No, ma'am.
No.
No, ma'am. Can you just explain on that?
No, this Arabin cervical pessary, the reason I put it here across is this is one of these particular studies, which is an RCT. Therefore, it has a lot of importance, and there are few people in our fraternity who are using it in their practices, and wherein it is just the cervical pessary which can be placed on. You can see in the picture here that it can be just placed on the cervix if it's a short cervix or so. And as I think Dr. Abhi or Abhishek was mentioning, that we have to not do it universally, of course, but then it would be less interventional than putting a cervical encephalage under anesthesia. That would be the advantage. And as he rightly said that, progesterone in prevention of preterm labor is not spoken about. And most of you continue giving progesterone till 34 weeks of gestation. Is that the practice, or when do you stop the progesterone? Or do you do a cervical length assessment to guide you, or progesterone continues till 34 weeks in your patients? Because if you look at this chart here, IVF ICSI pregnancies have a higher frequency of spontaneous preterm births compared to spontaneously conceived pregnancies, is one of the evidences.
Well, what I do is that for patients who are on progesterone, we generally stop between 8 and 12 weeks as a routine. Those at risk of preterm birth, we start with progesterone again at 24 weeks.
At 24 weeks. But then you don't do the 16 weeks transvaginal screening at the early anatomy scan to look at the cervical length, because that's what the FIGO, the ACOG, the German, everybody is recommending. Do we do it? Or you use the TIFA scan as the time point to do a transvaginal scan? What is it for cervical?
Somehow I feel that when we do cervical length assessment, we always end up missing it.
Okay.
Because we mostly go by historical things, people like twin pregnancy, anybody who has a previous history. And also, I wouldn't say I don't have much data on it, but I always feel that people with polycystic ovaries tend to have a slightly higher risk.
True, very true.
Basically, yeah, most of the studies are talking about transvaginal sonography. So if your radiologists are now getting doubled up and trained as fetal medicine specialists, so they, whenever they write their obstetric scan, even if you don't send your patient to a fetal medicine specialist, the radiologist may say that the cervical length is measuring 25 mm. What to do?
Madam, traditionally, we used to do, I think I still follow it, it's a fundal pressure testing. That is, beyond 18 weeks, we do a fundal pressure. And if a V or a U is dominant, we can take it as a clinical evidence of cervical insufficiency. And the first thing I would do is, again, exclude a local infection.
Yeah, Karthika, one of the most important messages, Bhavin, I'm giving through you is, please remember that cervix is not only a mechanical structure, but it can undergo breakup of its collagen under influence of inflammation and infection. And therefore, we have to target our actions towards it. Karthika is raising her hand. Yes, Karthika?
Yeah, ma'am. Actually, we do a routine prophylactic cerclage for all our multiple pregnancies. And if it is a singleton pregnancy with previous history of cervical incompetence or an early preterm labor, we do a stitch. Otherwise, it is like we screen the patient for the cervical incompetence. And if the cervical length is going less than 2.5, they will have a fortnightly surveillance. And still it is dropping, then we do a cerclage at that time and continue the micronized progesterone.
Yeah, so but definitely you'll give credence to looking at that, at least at the time when you're doing the anatomy scan or an anomaly scan. You will look at the cervical length and then follow suit, or you will depend entirely only on history?
Means regarding the encerclage, ma'am?
The cervical length assessment.
Yeah, if it is going below 2.5, then we do a stitch. Even if she doesn't have a previous history, then if it is going below 2.5, then we do an emergency cerclage kind. Otherwise, it is routine cerclage only for multiple pregnancies at after the NT scan.
What point in time during the antenatal period you would want to ask your radiologist or you yourself do the cervical length assessment is my primary question.
We have a specialized fetal medicine unit, so they take care of our antenatal patients. So after 12 to 14 weeks, all the scans are done by the fetal medicine unit here.
Dr. Abhishek wants to say something?
Yeah, I think the recent guidelines now say that it's below 20, but even so, we all we get a bit worried after 25. So what RCOG also says is that the use of micronized vaginal progesterone.
I think we lost you.
Yeah, one question which I had, madam, was that now we are putting a cervical stitch for preventing preterm labor or for cervical incompetence. So when we have a case of cervical incompetence, probably the stitch will work. But if it's a case of preterm labor, how is the cervical shortening later on in gestation when you put a stitch? How is it going to prevent the preterm labor from occurring when you put a stitch? Is the basic. That is one doubt which I have been having, because from what I've seen, I feel that the stitch is for incompetence, not for prevention of preterm labor. For prevention of preterm labor, probably progesterones and other medications which are there would definitely help.
Okay, so you have given the same point which Bhavin and I were talking. You have put it in a different form, and very good. That is very important to understand that these are two different issues. What about the twin pregnancy? I see universally all the ART, many of the ART, not all, put the cervical encerclage prophylactically for all twin gestations. What would anyone on the panel would want to talk about this?
We don't put it for twins or even for triplets as a routine. And for so far, I feel the results have been fairly good. I think it's a misconception, and also all the evidence has pointed that multiple pregnancies and in circulages, the data is very weak.
Absolutely. Thank you so much. And I just put up this very interesting slide here to show you this study which was done by this group and published in AJOG, where they have studied the pattern of cervical modification during pregnancy, especially in twin gestation. And you can see that there are various patterns that they have identified. And this is very interesting. So there's a stable cervix, there's an early rapid shortening in some of the patients. There can be late shortening in the others, and there can be early shortening with plateau. So therefore, various kinds of things that we see, what we have to pay credentials, of course, is to what is emerging, as Dr. Karthika said, and what has been the background, as Dr. Abhishek said, and that would help us in taking our calls. However, all of the panelists here agree that there will be no universal cerclage. Am I right? Please, can I have a raise of hands? So no universal cerclage, please, though the controversy continues. So we'll just stop it at this. What about growth restriction? Fetal growth restriction, I think the same surveillance we spoke about preeclampsia would be there. You would definitely do a growth at what time? What will be your growth scan analysis timeline? Or do you also take a look at the TIFA scan? Are there any sort of clues in the early anatomy scan which you would like to look into for a fetal growth restriction? Anybody?
Ma'am, typically for interval growth, we start doing scans after 28 weeks. Only when the baby's weight parameters or the measurement fall below the 25th percentile is when we supplement it with a Doppler and start intervening for fetal growth restriction. Otherwise, routinely, it is not before 28 weeks that I do anything.
Okay, anybody else wants to say? Of course, the PI and all these, the PAPE and everything at the combined testing will give you the markers, and these are the ones which you'll risk tag and follow. And maybe dietary changes, as Dr. Abhi has been saying, we have to be careful. Now, since we have less time remaining, placental complications is something that Shrutika, you mentioned, and we have to be on guard, especially because if you look at the risk factors for placenta accreta, it can be something that has happened on the uterus in the past. And especially very commonly we see low-lying placentas. So are there any signs where you would like to tell our viewers here that where you be on guard whenever you're looking at the placenta? You mentioned that you will look at it at the early anatomy scan at 18-19 weeks and be also sure about what is happening to the placenta. So are there any important markers where you should be a little suspicious about placenta accreta or morbidly adherent placenta?
Ma'am, many patients who have undergone any kind of hysteroscopic adhesiolysis, synecholysis, any person who has undergone a myomectomy, these are patients who are very much at high risk of developing placenta accreta, multiple DNCs in the past, smoking mothers, grand multipara, these are all risk factors for placenta accreta, especially those patients who have undergone a previous hysterotomy or a previous C-section. Especially in those patients, if I see an anterior placenta, then I always request for a Doppler window by the radiologist to rule out placenta accreta specifically. That is a note that I mentioned. Placenta previa patients, patients who have posterior placentas, these patients are usually counseled that we will have to keep evaluating the migration of the placenta. That is what I routinely practice.
So whenever you have a placenta which is in the lower segment, you'll be on guard, and wonderfully enumerated the risk factors, Shrutika. Thank you so much. And we have to just, do yourself or be on guard, and be on guard, especially for those particular gestational sacs which are on the lower segment near the scar in the second stage when there's anechoic placental areas and an irregular placental myometrial interface. And if there is a very thin, less than 5 millimeters anterior myometrial thickness. So these are the ones which would put us on guard and we have to remember. So in conclusion, I think all my panelists have beautifully put together this particular overview that you will do a continuous historical risk assessment in your patients through all the issues that are important, and then put them on a close surveillance. And all of them, we are having a wonderful combination of senior doctors as well as the juniors in practice. And all of them have unanimously agreed to the fact that wonderful surveillance has helped them in reducing quite a lot of complications in their ART patients. And one of the things which I would like to add here while we are on this chart is even pre-pregnancy optimization is extremely important. And I would like to put something in your minds as a thought, and that is the HPV vaccine. I don't know, somehow there is a lot of data which is supporting that human papilloma viral infections act as an inflammatory process giving rise to prom and preterm deliveries. And that can be one of the ways in which we may consider giving it prenatally to all our mothers, not only assisted reproductive technologies. And I think we should start thinking in that view, not only for cancer service prevention, but for HPV infection prevention can be considered. Now, the last part, in very quick, last about 4-5 minutes, I want somebody to tell us how to bring about successful lactation in our patients, because lactation failure or inability to breastfeed is one of the biggest challenges that ART mothers face. So are you doing anything prenatally for them to help them do this?
I emphasize them to learn from YouTube videos. I emphasize that they should be disconnected from the past social generation, because they have to come to 2021 to understand what is lactation and what is a woman. It is a woman who is important, not the man or anybody else. So that itself will debar the lady, and privacy is again third point important. So it is all up to the mind and the importance of socialization, everything. And especially in the times of COVID, we have to emphasize, and I have my very good blogger for my own patient. She's put up excellent videos, that is Dr. Shruti. I explained to them, and there are a lot of techniques they can learn, because the earlier mothers will emphasize that it is like a tap, you know, you open on the 5th day, it has to come. It won't come, yeah. And people also expect that engorgement is a very good sign. So they wait for the engorgement, it's a very good sign. So all those things we have to cut and just throw it away.
Wonderful, thank you. Anybody else wants to add to this lactation issue?
Well, it's a very common problem, and I'd like to just put 2 important points. The first one is that a lot of post-ART mothers have a emotional crisis post-delivery when they find it difficult to handle both the baby and lactation. So they have to be very well supported. The second thing is, unfortunately, for a lot of doctors and nurses, lactation is a low priority area. And you need to find out people in your team. It could be doctors, it could be nurses, it could be neonatology nurses who are good at supporting mothers during this time. And they are the people who should interact with these mothers before delivery and after delivery, and they do a wonderful job. So make these people the point persons for supporting lactation if you don't have a specific lactation consultant.
Okay. Anybody? Kartika wants to say something?
Ideally, you have to start the preparation in the late 3rd trimester itself. Like most of the people may have a short nipple or anything. You can start doing a massage with the oil or a cream or anything. And we usually have the NICU team, which give them a proper counseling and teaching how to breastfeed, what is the position and all that thing. So, and what I feel is most of the time this bonding between the mother and the baby becomes an issue, especially in this donor cycles. So these people are usually counseled before, given a psychological counseling so that they don't have any issues postpartum, mainly in this donor cycles.
Ma'am, one additional thing that I feel is a lot of ART mothers end up with a cesarean section, and when there is no rooming in of the baby with the mother, they typically develop that fear, because since there has not been any oxytocin release, if it's an elective cesarean section, they typically don't have any colostrum for the first 24 hours. And that is when the anxiety creeps in and they start over analyzing the situation and thinking that they have complete lactation failure. So in such cases, I usually involve a lactational counselor. I emphasize the mother always to try and ask the baby to put the baby at the breast and encourage suckling, because that is what is going to kind of release the colostrum or release the milk. And I always counsel them about how much quantity of milk should they consider as adequate. So usually the guideline is that a thimble full of milk is all that they require for one feed. Usually there is disparity in the expectation of the mother. That is, they don't understand how much milk is the baby going to require. Is it a lemon-sized amount of milk or a thimble full of milk? So when a lactation counselor speaks, it really makes a difference, especially in multiple pregnancy, teaching the baby mothers the position of breastfeeding. There is something called as a football position of holding both babies and putting them at breast. all those interventions really help, and then such mothers don't have lactation.
When you're doing a lot of assistance in getting them pregnant, it's also your responsibility to give them a lot of assistance helping them breastfeed. I think that's an important message, and we have to do this because we have to ensure future health for the mother as well as the baby. I think I conclude this panel with a lot of thanks and gratitude for giving me this opportunity. And it was a wonderful contribution from all the panelists, and I want to put my hands together into clap. And all of you are supposed to smile here into the screen because I'm taking a wonderful screenshot. So please smile and look beautiful and handsome. Thank you so much. I'm going to send it on the group, and I hope I was able to cover everything and do justice to everything that was needed. Thank you.
Thanks, Dr. Girija. That was a wonderful panel. And let us take very few questions because we have got less time.
Yes.
One question by Dr. Ladika. Can you guide what is the ideal prescription after embryo transfer? That's a difficult question.
Should take this, yeah.
Difficult question. I think all the panel members doing IVF can answer that. At least what they are giving.
Secrets away.
Pardon?
Nobody wants to give the secrets away.
No, at least there's a good question because good but difficult question to answer. But at least all the panel members, if they can tell one by one, ideal prescription after embryo transfer. We'll start from one.
There is no ideal prescription. It is always individualized care and individualized therapy. That is the #1 rule. Yes, I think throughout the panel we have mentioned that progesterone supplementation in the adequate dosage, that means a 10 milligram of dydrogesterone 3 times a day, or around 600 micrograms of micronized progesterone. You need to choose your route of delivery, whether it's oral or vaginal. That is one thing that is required. In all ART cycles, there is a corpus luteum defect that is formed. So supplementing estradiol valerate is also very much important. You can't skip your estradiol valerate. So those are the two things that are mandatory. The third thing is if the patient has undergone a fresh transfer, then after ovum pickup, we would add antibiotics to cover for the egg retrieval. That goes on for 4 to 5 days. The third thing that you assess from the risk of the patient is whether the patient is going to require low molecular weight heparin or aspirin. So that depends on whether the patient is obese or whether the patient has any past history of VT, thromboembolism, any associated medical conditions. Then adding low molecular weight heparin or aspirin is an option that is there. But essentially, the ideal prescription is basically progesterone and estrogen. I think I'm not missing. Request my co-panelists to add.
Yeah, you need to add folic acid also, probably.
I tell you something, there is a lot of movement amongst the neonatologists, especially in our Cloud9 hospitals. We are considering giving DHA for prevention of preterm labor. And this is also happening in, we had a study, in Bharati Vidyapeeth University Medical College. We do a lot of nutritional research. And we have found DHA supplementation helps in bringing about better outcomes. So I think we'll need a lot of evidence for that. So sometimes I feel ki acha khana khao, that is your DHA. Why you have to take it through supplements,
And with the amount of fish we here to eat in Kerala, we don't think
we don't.
Yeah. Even progesterone itself will prevent preterm labor, especially vaginal progesterone. Don't you think so?
That is something that is, madam, because preterm labor has so many multifactorial reasons now that progesterone would probably act only on one factor of that. Those things is what is believed, and therefore we are not able to pinpoint. As Dr. Bhavi, Dr. Abhi and Shrutika have been saying, that looking at everything holistically would be really important whenever we're talking of. But yes. Any more things, Fessy?
Madam, anything else? Madam?
Yes,
the thing is, I think routine checking for vaginal infection should be done, because in the beginning stage, 90s, I had a case of ovarian abscess following oocyte retrieval. So after that, for every ET and probiotics are given during and before and after the procedure.
Okay. Sir, I think as already we are 50 minutes past 12 o'clock, we will go ahead with the next panel. I think thank you for all the panel members and the moderator, Dr. Girija, panel members, Dr. Pavin, Kartika, Abhishek, Raghavendra Prasad, and Sudhika for giving all contributed well, and we have got a lot of response to the chat box that all covered all the, especially the controversial and important practical points has been covered. Thank you all for wonderful inputs to the panel.
Hi, Abhi.
Okay.
I see.
Thank
you, ma'am. Thank you very much.
And Girija, it was an excellent panel. I enjoyed it thoroughly. I got everything, and all the panelists, they were awesome, as well as the viewers and their tips.
Okay, I think we will go out with the second. We will introduce the second panel.
Thank you, Madam Pillai. Namaskar. Thank you. I don't know whether it was audible. Yeah.
Yes, yes, it was audible.
Good morning, ma'am.
Okay, I think we will start with the next panel. We have a panel on use of gonadotropins for ovulation induction IUI, and moderator is none other than vibrant and energetic Dr. Seema Pandey. She is the director of Seema Hospital and Eva Fertility Clinic and IVF Center, Azamgarh, UP, president of Azamgarh Obstetrics and Gynec Society, and national executive member of ISAR, co-author of A to Z of PCOS, everything you wanted to know about PCOS, coordinator of WAXI and handbook on drugs in infertility, which was released last year and as a big hit, and Foxy focus on preterm labor, and Anemia Journal, and key interest is infertility and reproductive endocrinology, PCOS, adolescent health and early pregnancy failure, and spreading awareness about PCOS and adolescent health among rural women and school girls through the health checkup camps and talks through the NGO Surabhi. Okay, and next we will quickly introduce the panel members. Next slide, please. Next we have in panel Dr. Raju Nair. He is a fellowship in the reproductive medicine from CMC Vellore, director and head of reproductive medicine at Nithya Hospital, Kottayam. He's a member of SHA, SRM, ISAR, Foxy, IAG, ACE, and a lot of organizations. Review of Cochrane Network in fertility in scientific publication, 11 original articles at index journals, and 3 national best papers. Invited speaker to many national meetings. Area of interest is IVF, lab quality, PCOD, and minimal stimulation. Welcome, Dr. Raju. And next we have Dr. Jitendra Behera. He is a consultant in fertility and laparoscopy at IRMC Jesus Hospital at Peridhalmanna, Malappuram. And he's done a fellowship in reproductive medicine and the ex-IVF consultant at SRM Hospital, Chennai, ex-assistant professor MMC Pondicherry. In publications, fetal maternal outcome in thyroid dysfunction pregnancy published in Jogi. Especially interesting is the field of reproductive medicine and endoscopy. We welcome Jitendra. Next. Next, please. Next, we have Dr. Hari Kumar. Hari is a consultant in reproductive medicine at NS Hospital, Kollam. Graduate from Medical College, Trivandrum, and post-graduation from Jigmar, Pondicherry. FNB in reproductive medicine from Women's Center, Coimbatore, and consultant in NSIRT. IRT Center since 2009. Welcome, Dr. Hari. Next, we have none other than Dr. Ram Gopal. He is working as a reproductive medicine consultant and endoscopist in the Samadha Hospital, Kerala. Fertility consultant at AMBC Clinic, Matthews. And areas of interest trained in andrology under Dr. Ashok Agarwal, Cleveland, Ohio, from Ohio, USA. Trained in embryology at Asia Pacific Institute of Embryology. And he is a special interest group embryology member in 2018, editor ISAR Kerala Chapter Journal since 2016, and sub-editor ISAR Kerala Chapter Journal 2015 and 16. And welcome Dr. Ram Gopal. Next we have got Dr. Sandhya Krishna from Calicut. She is a FNB reproductive medicine from Bangalore, under Dr. Kamini Rao. And did PGDMLE from Bangalore 2014, presently senior consultant in care IVF Center, Calicut, and authored Foxy Focus 2010 IUI Ward ACMR guidelines, textbook of ART chapter evaluation of infertile female in 2016, Textbook of IRT in chapter batch IVF in 2018 research work comparing outcome of pre-treatment with OCP in antibody cycling for responders 2010, comparing SUMUP versus density gradient method of 7 parameters for IVF in 2012, comparing conventional antibodies protocol versus microdose Bayer protocol in 4 responders in 2014. National faculty in ISAR since 2011, organizing committee member of ISAR 2019 Kerala chapter, and reviewed board member of IGI IMF International Journal of Infertility and Fetal Medicine 2012, IMA Women's Wing Secretary Calicut 2016. And topics of interest is PCOD for responders and medical legal ethics. We welcome Sandhya to the panel. And next we have, next slide please. Dr. Neha Priyadarshini. She's a fellow in reproductive medicine and medical director of Satwik IVF Dhanbad, founder secretary of Jharkhand ISAR, youth leader East Zone Young Talent Promotion Committee of FOXY, champion of ISAR award at annual ISAR conference at Hyderabad, bestowed by the Nari Samman Award by Sahitya Academy 2019, Best Doctor Award by Dainik Jagran in 2018, credited first IVF baby of Dhanbad, the Cold Capital of India in 2015, All India topper in ICG Fellowship of Reproductive Medicine exam in 2014, CLJ Award for Best Paper at AICOG 2011, published many papers in journals, invited in many conferences, faculty. Area of interest is infertility and high-risk pregnancy. With this, we'll go ahead with the panel, and over to Dr. Seema for the panel.
Thank you so much, Dr. Fessy, for such a kind introduction. Good morning, dear friends. On behalf of Team ISAR 2021, I welcome you all and my esteemed panelists on board. And today we are going to talk about use of gonadotropin in our IUI cycle. So friends, we believe ASHRAE and HIFA, according to them, single embryo transfer with mild stimulation and results of IUI are almost at par. And recent meta-analysis done in 2020, along with those guidelines which were being published that oral ovulagens should be the first line of treatment for IUI, the same time, this meta-analysis came over more than 3,000 patients, and which has clearly concluded, if we talk about live birth rate, clinical pregnancy rate, and ongoing pregnancy rate, gonadotropins, they top the list. The only problem is associated multi-fetal gestation. And in the same meta-analysis, they have concluded that is not a big problem, provided we have counseled our patient very nicely, we have selected our patients very nicely, and we have strict cancellation and monitoring policy. On this note, let's start our panel. All of you, I would like to be more discussing more, not theoretical, whatever we are doing in our practical day-to-day life, along with few evidences, of course. So let me share my slide first. And I hope all of you are doing well as Tom has started settling. There is a big sigh of relief. Can you see my slides now?
Ma'am, am I supposed to share a video before this?
Yes, sorry. Before that, on behalf of Team ISAR 2021, I want to spread a message for all of you, and I would love that after watching it, keep sharing among your groups, societies, so that many people, they start getting benefited by all these schemes which ISAR has. are the people who have already got accreditations. They are pictured along with us. So this membership drive, SAD has put a price on it. The society which gets maximum number of patients and number of registrations, they are going to get awarded for that. So please keep sharing, keep applying for your patients who just deserve these kind of things so they can be helped to us.
Dr. Seema, I think you joined late. I have to tell that.
Oh, I was there. Yeah, 15 minutes late. I was. Yes.
Okay, we have got 22 new members applied for Kerala. That is more than 40% of our membership. So I read the names of
Kerala Society. Yes, Bessie, please.
No, over to you. Over to you.
So welcome again. So, and we are taking into consideration the patient which we are going to talk about. You have already investigated. We know that one tube is patent, her ovarian reserve is reasonably good, and you are planning to do her IUI. So, what are the situations where gonadotropins come to your mind whenever you are planning to do an IUI? So I'll start from Dr. Raju.
Yeah.
I cannot see
Madam.
the panelist.
Yeah, especially gonadotropins plus IUI, as per the evidence, definitely will give you a better success. So I prefer gonadotropin if you look into an indication perspective, especially in those patients with unexplained infertility and endometriosis. I prefer gonadotropin over oral therapy for IUI.
Yes. Dr. G.
Yeah, mainly for unexplained infertility and for endometriosis, I prefer gonadotropin IUI rather oral therapy.
Especially in case of clomipene citrate resistant CC failure patient, we can start gonadotropins even if you have tried like 3 to 4 cycles. And in case of like WHO criteria like hypogonadotropic hypogonadotrophic type of patients where when we are doing the FSH and LH is very low, in those cases also we can directly go for gonadotropins. And as already sir told, like unexplained infertility and elderly patient also we can start gonadotropins.
These 3 are very important indications you have told about. Dr. Hari, do you want to add something?
Yeah, actually, when it comes to there are 2 basic indications. One is
indications which are already which are not covered yet. Yeah.
Yeah, anovulation, because there's no doubt regarding that, no debate. But when it comes to unexplained infertility, which as Dr. Raju is finding early endometriosis and many other patients, that is unexplained, there's a debate world around because as around fails, it's of no use or it adds to the complications. So it's not to be followed. But practically speaking, in a low resource setup especially, there is a definite role for the gonadotropins before thinking about the IVF. That's my take.
So yes, Dr. Sandhya and Dr. Neha, do you want to add something?
Yes, ma'am. At least 3 cycles when the failure of response to clomiphene occurs, and minimum 6 cycles when the patient has ovulated but not conceived in cases of mild male infertility cases, in unexplained infertility, and when there is 2 or more miscarriages when CC was used. In those cases, gonadotropins are added.
These are excellent add-ons. Dr. Sandhya, your input, please. Please unmute.
Hello?
Yes.
Yeah,
you are audible now.
So in a patient who has already undergone 1 or 2 cycles of IUI and we have got only a single follicle and they have not conceived. So I want more number of follicles to develop in those patients to give a better chance. So that is one indication. And where there is a shortage of time, like the patient has got only 1 or 2 months and the husband is living, or the patient is elderly, in those patients I would like to add gonadotropin.
Okay. So our esteemed panelists, they have almost covered all the indications, practical and theoreticals. So my next question is, whenever you have decided to go for gonadotropin IUI, do you believe in pre-IUI optimization? And if yes, then what do you do? And what are those candidates where you want to do all these things? So I'll start from Dr. Sandhya at this time.
Dr. Seema, if it's regarding the general health, like I would like to check up if she has anemia, if she has hypothyroid, and any other health issues which needs to be corrected. Like if she's an anemic, then I would like that to be corrected. If she's a hypothyroid or a diabetic with an increased HbA1c, I would like those things to be corrected. And also I would like to have a synchronized cohort when I start her on stimulation on day 2 or day 3.
So Dr. Neha, do you, since this poor ovarian reserve slide is put here, and my question, do you believe in DHEA before your IUI cycles in these patients who are having respectively poor ovarian reserve?
Ma'am, depends on age of the patient and AMH of the patient, how long the patient has been married. These things are the practical aspects we take into consideration. So if the patient walks into my clinic at 38 years age, married since maybe 3-4 years, mild male factor, and the patient is going to go outstation, out of country and here for 2 months, I will not waste my time in giving DHEA. I would rather, looking at the follicles, if there are, like at least 1 or 2 follicles, I would rather go for an IUI than wasting my time in DHEA. If I have time and if the age of the patient is less and AMH is slightly on the lower side, just slight lower, then I might add DHEA. Rather than that, apart from this, like if the patient is having a high AMH and a high LH, I would rather add a OCP 1 cycle before to decrease the LH levels. In patients who are insulin resistant, I might add metformin 2 or 3 months prior to IUI cycles. So depends, a lot of our clinical practice depends on the age, the duration of infertility, and what is the time period the patient is allowing me to work on her.
Excellent. So Dr. Hari, do you want to add something?
Yeah, on the side of Neha, most of the things she told, but regarding adding OCP activate, I do doubt. Regarding DHEA, worldwide, actually there was a hype regarding DHEA for quite some time. Now, the literature circles believe that DHEA may not be that effective, considering that you need to give the therapy for quite a long time to at least see some fringe benefit, which should be compared with the age factor. So, as Neha told initially, age and the duration of fertility does make a difference in the treatment. Even the setting is the poor ovarian reserve.
So I cannot hear you clearly. Your voice is crackling a bit.
Okay, and I go with Neha most of the things she told, except regarding the adding OCP and the DHEA again. Now the prolonged DHEA treatment might be a wastage of time compared to the time we lose in terms of the age of the female. So when it comes to the older ladies, or they have a prolonged infertility where already they tested their fertility potential, it may not be the right way to do DHEA.
Very nice. So Dr. Jiten, do you want to add something about treating with DHEA or pre-optimizing your IUI cycles for these above indications we have already discussed?
Yeah, I never used any giving OC pills and in the first cycle and then optimizing, and then you should go for this thing. Especially like as Sarah told, like DHA, I am if you are the patient AMH is very low. So even if you are going for gonadotropin cycle for IUI, so better you can give the DHA and simultaneously you can continue the cycles.
Perfect. So Dr. Raju, your input, please.
And I think I go ahead with what Dr. Sandhya Krishna has put forward. basically we pre-optimize for the patient's well-being. For getting a more number of follicles, adding DHA just for an IUI cycle, I may not add to it. Maybe if the patient is planning for an ART cycle, like an IVF cycle, maybe if the AMH is low, I may put the patient for DHA for the so-called benefit. It may happen because maybe some benefit for the future. But for an IUI cycle, I won't waste patients' money for that.
So my panelists, they are in sync with the opinion that they don't want to use useless drugs or extra drugs for anything. It's more about their lifestyle, monitoring their lifestyle corrections, and whatever problems underlying is there, they should be corrected. So am I right? Yeah. So in tune with that, one thing I would like to add, if you are going to do an IUI with gonadotropin for mild to moderate male factor infertility, please get a fresh semen sampling done. And if count is pre-wash motile count is around 5 million or more, then only proceed for that. Otherwise, patient is going to get so many injections. She is going to spend a lot of money, this couple. And make the diagnosis, treat accordingly. There are many nutraceuticals companies, they are booming up, they are after our head, use this, use that. Use your own insight, what are you going to do and how are you going to use it. And in case of any problem, after correcting, please give at least 3 months before starting a gonadotropin IUI. That was my message. And whenever you are starting an IUI, what are the principles do you follow while stimulating? And what is your aim usually? So this time, Dr. Raju, please you start. I'm just going through sequence.
Yeah, by stimulating, my aim of stimulation for an IUI cycles will be obviously not for a monofollicular development. My aim should be for at least 2 to 3 follicles, and obviously not more than 4. So that aim of 2 to 3 follicles should be, channelizing the gonadotropin therapy to aim at that recruitment is my policy.
Okay. And Dr. Jitin?
Yeah, first of all, we have to think about to create more follicles. Second, control the timing of the insemination. Like we have to means that is very important if somebody is having irregular cycles and you are planning to do the IUI within like 14th or 16th day. So that is the best option for the gonadotropin if you are starting, then you will get the result. Second thing, you have to, third thing is that you have to think about the multiple pregnancy. In case of gonadotropins with IUI, that is another aim. Then fourth is like you can prevent for LH search, premature LH search.
These are excellent points you have raised, Dr. Jitendra. And if Dr. Hari can add something quickly.
Yeah, Dr. Seema, I beg to differ to my friends, especially Dr. Raju. Yes. You have to demarcate the indication. If it's for anovulation, you have to aim at monofolliculogenesis.
Spot on.
And if it's unexplained infertility or so on, it has to be polyfolliculogenesis. Actually, we have to be beware of the complications arising out of polyfolliculogenesis. So it's regarding what indication you are doing as superovulation depends, decides what the dose and why you are doing and how to stimulate.
Sorry, Dr. Ram Gopal, your picture was not visible on my screen. The next question is,
sorry for the inconvenience.
So the same question I'm repeating to you. Do you want to add something? Whenever you are doing any cycle, be it TIC or IUI, what is the principle? What is the aim?
Ideally, according to the indication, we would like at least 1 follicle to grow and development of one mature oocyte being ovulated. But in other cases, we can aim at the development of 2 to 3 follicles at the maximum. If 3 or more, and plan otherwise. So the dose will depend on the patient, like Dr. Harikumar sir had said regarding whether the patient was having anovulation or subtle ovulatory defects only. And then as we are iatrogenically giving medicines for the development, we should follow up in such a way that we don't put the patient under increased risk of OHSS or multiple pregnancies. So we should be following her up with ultrasound ideally. And in special cases, only more follow-up will be
Come to
needed.
monitoring later on. First of all, we are just talking about principles. Thank you. So Dr. Neha and Dr. Sandhya, quickly, do you want to add something in this list, which has already been covered? I don't want repetition, please.
Yes, yes.
To
would
achieve
like
pregnancy in the shortest time possible.
Yes, that is the most important. The most important thing is shortest time to the pregnancy without giving much complications to this couple or lady. So I think my panelists, they have covered everything very beautifully. So it should be monofollicular in anovulatory, unexplained 2 to 3 endometriosis, others, all the other factors there, we aim for 2 to 3 follicles, and our aim is to achieve pregnancy in shortest time duration, at the same time avoiding OHSS and multiple pregnancy. So
Madam, can I put a why we are especially patient is anovulatory, why we are putting the fair that we are aiming for a monofollicular development? Because if you're planning for an IUI, suppose it's for a timed intercourse, okay, you aim for a monofollicular development. But if it is for IUI, if you have more number of follicles, obviously your chance of pregnancy will improve. So whether it's an ovulatory patient or anovulatory patient. So your fear of stimulating more in an anovulatory patient is a chance of going for an hyperstimulation, isn't it? So if you are have a control on your stimulation and still you are able to achieve a follicles of 2 to 3, will you be happy in aiming for 2 to 3 follicle rather than a monofollicular development?
more than happy. I completely agree with you. And that is a learning curve that comes with experience. Yeah, Dr. Hari.
Yeah. My concern is about the multiple pregnancy rather than the OHSS. So singleton pregnancy is my aim. So still I would debate regarding the polyfollicular disease, even if it's 2.
Given the verdict that pregnancy rates are better with bifollicular development, be it any indication. Dr. Hari, do you still want to debate about it?
Yeah, still, because considering the huge difference between a multiple pregnancy and a singleton pregnancy, I would rather go with single follicle in spite of having a 5% less pregnancy rate per cycle, considering I would like to treat one more cycle rather than having a multiple pregnancy.
So excellent. I just respect your view on this, that you don't want to give, your aim is to give a healthy child to a healthy mother, not just a pregnancy. And there this dictum really plays a good role. So what are the determinants of success of any IUI cycle? I'll go to Dr. Sandhya.
We need to select a proper patient for the IUI, and my preference would be definitely HMG first, because
no, sorry, this question I'll ask later. I was asking you determinants which just give you the successful IUI.
Yeah, proper patient selection for IUI. Like the age factor, younger the age, more would be the success. Lesser the duration of infertility, again, more are the chances. And the treatment cycle, first, second treatment cycles stand the maximum chance. Semen quality, mild factors in male factor, like the people who have delayed liquefaction in semen, I especially choose those patients because they have a high success rate in IUI. And like they usually come with 5 to 6 years of infertility, and when this one factor is found, and if you do an IUI, they would most probably conceive. And the number of follicles at the time of insemination, like the more the number of follicles, more the chances, but beyond 3 follicles, the chances reduce. So our aim should always be up to 2 to 3 follicles, not more than that. The IUI technique does not have much effect on successful IUI, except that there should not be any difficulty. Like if the sample has reached the proper place, intercervically, if you are able to inseminate, then it should do that purpose.
So do my panelists, they agree with the list? for determinants of successful IUI. We'll pass it very fast. That's why I'm asking, and I hope all of you agree on these points.
Madam,
I do have had the liberty to alter the sequence in this order.
I will do it. Age is on the top. Age
should be on the top. Duration of infertility should be second, and cause of infertility, especially in severe male factor, we are not going to do an IUI. At least 5 million motile sperms per inseminate should be there. So causes of infertility may not be that important compared to the age and the duration.
Exactly. So I completely agree. I didn't get time to revert because I made it till morning. But yes, you are absolutely right. I just forgot to do that. So coming to the next question, my next question is to Dr. Ram Gopal Pillai. What is your choice? And I want to know the real choice which you people are doing in your day-to-day practice. What is your preference, HMG or FSH?
It depends on the patient. She has a history of being treated with oral ovulogens and which was not successful, whether it is documented whether ovulation occurred or not, or after ovulation has been documented she didn't get a pregnancy after around 3 to 4 cycles of oral ovulogens, then I will start with HMG or FSH, which will depend on the patient. But first I will start with oral ovulogens, followed by this only.
No, we have just come across that we are focusing on gonadotropin IUI. Mixture, I'll come later. I just want to ask you, if you are going to use gonadotropin, what is your preference, whether be it HMG or FSH?
I'll start with HMG first.
HMG.
Yeah.
Dr. Neha, your choice?
Ma'am, again, that depends on patient's profile. Like, because I belong to Jharkhand, where the literacy rate is less than 50%. Per capita income is 1/3 of what Kerala has and half of our country. So if a patient walks into my clinic for IUI, I have to understand that they have overcome many social, cultural, and financial.
Neha, I'll interrupt you. I am asking about gonadotropin IUI.
HMG.
And that is very simple. I'm not asking anything else. I'm just asking once we have decided. So anybody,
because it is cost effective per cycle.
Yeah. Anybody has a different opinion regarding the use of HMG versus FSH? Dr. Sandhya, Dr. Hari, Dr. Jitesh,
Yeah, I do have.
Raju.
Yeah, madam, actually we have to go first to see the profile of the patient. Like you have to check LH and FSH. If the LH is high, like especially anovulatory cycles PCOS patient, I will prefer FSH. I know it is a little bit costly, but definitely it will get the result rather than starting with HMG. Whereas in case of pituitary failure cases, in hypo, in those cases, we can start with HMG and we can get the result.
At this age, when PCOS are being stimulated by HMG in IVF cycles or combination of FSH, LH, do you still believe in doing FSH, LH before an IUI cycle? First thing, is it cost effective? And second thing, do you decide your HMG according to this? How many of you do regularly doing this FSH, LH testing before an IUI cycle and deciding your gonadotropin as per that dictum? Dr. Raju, what is your opinion?
No, I will not. I will not do routine hormonal testing for FSH, LH or testing for
Absolutely.
IUI. But definitely considering my choice over HMG over FSH, very honestly, I prefer FSH just for one thing, basically the causes of concern to be looked into about the batch-to-batch consistency. Because I prefer to go for a recombinant FSH that saves time and money for me as well as for my patient.
Okay. So Dr. Sandhya, your expert view on this, how do you decide?
I don't do FSH and LH routinely for IUI patients, except for PCO patients. I would like to know the day to LH just to find out the group who are having high LH. It's not to decide about the gonadotropin, it's just to add some extra dexamethasone needed for the initial 1 week to 10 days.
So that brings that question again. Do you believe in high LH? Because internationally, people are not giving any importance to the level of LH before starting a stimulation in polycystic ovarian syndrome patients. So does it matter to us?
I still have a concept in patients who are giving history of recurrent abortions and severe
yes, that is
PCO with increased stromal thickness. If this small thing can add or help in increasing the success rate, I do go for it.
Yeah, so that could be a small subset of people where measuring LH going accordingly could help. But in general, message is that LH testing is not important before doing an IUI cycle, provided you have already made your diagnosis. If you have to do it for the first time, obviously you'll be doing it.
Yes.
So, and when you are using FSH, urinary versus recombinant. So Dr. Raju has clearly stated that he prefers recombinant. Any of you, Neha?
Recombinant.
Recombinant. Dr. Ram Gopal?
Yeah, recombinant has been proven to be better in some studies, but then we can try with urinary, and if no pregnancy or we are not getting the desired result, we can change to the costlier option.
And Dr. Hari, Dr. Jitendra?
Yeah, actually, this is one place where both.
Yeah, what are you saying? Hello, we have lost you. Till then, can Jiten take over?
Yeah, madam, actually, we have to see the socioeconomic
So it's pretty clear that you can use both. So as Dr. Raju was telling, recombinant holds a better profile in terms of batch-to-batch consistency, and more importantly, administration.
Ease of administration
and adjusting the dose. You can go down to 25 units.
12.5 units.
Yeah. And when you are dealing with a thin PCOS lady, that's the indication which I tend to use recombinant FSH. 18 BMI lady walking into your practice with obvious PCO, I'm scared for it. I will be using recombinant FSH in this particular lady in spite of the huge cost incurred.
I completely agree with you, Dr. Hari. That is a candidate where even though I do not use FSH that to recombinant in my IUI cycles, but that would be a real candidate where you can think about adding a recombinant FSH for ease of administration, doses adjustment. Yes, Dr. Jitendra, you were trying to tell something.
No, ma'am, I completely agree with Hari Kumar sir.
Yes. So as per our literature review, the same thing, that in terms of live birth rate and risk of OHSS and everything, all these, they give equal results, equal performance. A recent study, very recent, it has come, it's not a meta-analysis, so I didn't want to quote, which is quoted that RFSH gives better pregnancy rate. So whenever I think on those terms, it is more to do with batch to batch, variability, purity, consistency, all those factors, they might be playing a role. So for all the practical purposes, use what is suitable for your practice, what your patient can afford in terms of results and evidence, all work equal. So no difference in their performance. I think that is one question where we have already discussed this, that whenever we are thinking about recombinant FSH, it is because of these factors, but HMG is really cost effective. Response unpredictable, I don't think so. I don't agree to this point. And if you are using it regularly, you know your follicular monitoring, you are doing it on your own, I think it doesn't arise. This issue doesn't arise. So manipulation of dose is really important, and that is tough with HMG. So now the favorite question for all of us, how many of you before going for pure gonadotropin IUI, you try to do a mixed kind Ovulogen plus gonadotropins, and what are the reasons you are doing these cycles? So I'll start with Dr. Raju this time.
My majority of the cycles are combination cycles along with letrozole. So I usually give letrozole along with the recombinant FSH. The usual protocol, which almost I should say 80% of my protocol, start with 5 milligram of letrozole and adding recombinant FSH on day 5 or 7 or 9. So almost, I should say, majority of time, we didn't have much of a complication. I mean, some set of PCO patients we do add a little more time in getting follicles. Otherwise, majority of time we'll be happy to have this protocol. The advantage of this mixing up protocol is one is cost constraint, because adding oral ovulogel, we can decrease the amount of injections of gonadotropin, so that will be a huge saving. And obviously, the total dose of gonadotropin required can also be reduced, more or less the same.
Cost factor is one important thing you keep in mind. What about you, Dr. Jiten?
Yeah, whatever sir has told it, I am completely agree with sir. Like I also used to start letrozole and followed by I have to tell the patient.
So one cycle all of you do with ovulogen plus gonadotropin before switching completely over to a pure gonadotropin cycle. Dr. Hari, am I right for you too?
Yeah, very correct. Except for a thing, I do usually use a combination because of the commercial reasons. It's economic. And another aspect is a very obese PCO lady and hirsute lady, and she may not respond to oral gonadotropins or may require very high doses. If it's combined with oral ovulogins, she might respond at much lesser dose. So that is one particular area where, in spite of paucity of literature, because this is practiced mostly in India only or in the Asian countries, in spite of paucity of literature, we can try the combination in this particular subset.
So, Dr. Hari, this is a very good point, and I'll tell you there is plenty of literature, especially about letrozole or aromatase inhibitor. If it is added with gonadotropin, it decreases the requirement of the dose of gonadotropin. So that is a proven thing. And if you are doing that, that's very good. So, Dr. Sandhya?
Completely agree with this point, Dr. Raju and Dr. Hari, that oral ovulogins I add, always add. Even in IVF I add. I never use pure gonadotropins.
And Dr. Neha and Dr. Ram Gopal, do you agree with all the points discussed till now?
Absolutely, ma'am.
So this is just tabulation for our viewers to make a difference who are interested in starting gonadotropin IUI cycle. So they should be knowing and they should be noting out. So there are two regimens as we have already discussed. So how many of you are doing this conjunctional regime? And what is the difference between conjunctional and sequential regimen? In very short, Neha, can you just highlight the important points here?
Ma'am, in this regime, actually, gonadotropin helps in recruitment of the follicles. When we add it on day 3, on day 5, day 7. So gonadotropins along with oral ovulogins helps in recruitment of the follicle, which is beneficial in certain group of patients. In sequential, we first give a low dose and then increase and then decrease. So at times it is difficult to control a cycle.
So Dr. Sandhya, do you want to add something?
Yeah, here conjunctional means like we are starting the gonadotropins along with the ovulation on alternate days. This helps in recruiting more number of follicles. The earlier we start the gonadotropin, we are able to recruit more number of follicles. And at some stage, like after day 8, we have stopped it because the concept is once the follicles have reached 14 mm, they will grow on their own.
So Dr. Raju, Dr. Hari, Dr. Jiten, Dr. Ram Gopal, do you want to add something?
Ma'am, I don't know about this conjunctional regime. I'm used to this step up, step down, or chronic low dose. But
Okay.
Conjunctional, I'm not used to.
Anyone else? Dr. Jitendra, Dr. Raju, Dr. Ram Gopal, and Dr. Hari. Whom am I missing? Let me see all their faces. Yeah. So I will, if you people don't want to comment, I'll just do it quickly. There are two regimens, conjunctional and sequential, isn't it? So in conjunctional, there are two concepts, FSH threshold and FSH window. When you are using in conjunction with your oral Ovilogen, your aim is to raise the threshold for multiple recruitment. And that is done in those cycles where in your previous cycle, your oral Ovilogen did not give you optimal number of eggs. While in sequential regimen where you follow afterwards, it is, am I speaking opposite or?
No,
No,
you are audible.
no, ma'am, you're right. Yeah.
Yeah. So there our aim is to extend the window. So you get follicles get enough time once recruited to grow. So that is the main difference. And most of us, we don't want multifollicular development. So we first give Ovilogens, and then from day 5, day 6, we start giving our gonadotropins. People, most of the people, they believe in it should be, ideally it should be given every day, but because of cost cutting and other factors, they can give it on alternate days as well. So this is the only difference between conjunctional, and then you start your scanning from day 8, day 10, and once the follicle reaches 18 to 20 mm, you do everything the same way as you do in any other cycle of yours. So this is a picture depiction of the same. And these are two cycles, when two types when you are practicing this combination therapy. So for the beginners, I will say that mixing up apple and oranges sometimes leads to difficulty in managing. So you should just stick to either Ovilogens or gonadotropins. And people who are experienced or gradually they become experienced in manipulating and doing things, they can use anything. So that is the difference. So now you have decided that even your oral Ovilogen plus gonadotropin cycle did not work. Now we are talking about pure gonadotropin cycles. How do you decide the dose of gonadotropin in your cycle, Dr. Jiten?
We have to check the BMI of the patients. And one is BMI, second is your number of the antral follicle when we are doing the scan on the day 2 or day 3, and as well as AMH also will be considered for the deciding the dose of gonadotropins.
Excellent. So Dr. Hari, do you want to add something?
Jiten was spot on, but my hands are tight. I do have HMG which has only 75 units, so I don't have much choice except in a very small percentage when I'm using recombinant. So all about starting 75 in a low dose protocol or a chronic low dose protocol in anovulation.
75. There's no problem.
If it's unexplained, it's 75 anyway. Very unlikely to start at least in the first cycle above 75.
So you don't see anything irrespective of the age, weight, AFC, AMH, you start with 75 HMG?
In a cycle where you don't have any control, unlike IVF, I don't want to start beyond 75 in any case.
That is a very important message. But the message I wanted to give here, what are the tests which give you a confidence that this dose should work for this particular lady? Dr. Raju.
I think I put different sort to it. One of the things which I will look into is whether the patient is a PCO or non-PCO, along with the points which Dr. Pagara taught. Because if the patient is a PCO, definitely the starting dose, I agree with Hari that I may not go beyond 75. But on increments, the major decision will be a PCO or non-PCO because increment routes may change. Other than that, AMH will definitely help you in formulating in the dose. But majority of the time, I start with the blanket therapy of 75, very honestly.
Dr. Ram Gopal.
Another factor which will help me in deciding the dose will be her previous response also in the previous cycle.
Is very
if I am planning for a cycle, only.
Yes.
Yeah, so for these PCO patients, and as Dr. Jitendra has told, thin, lean, young patients with prone for PCO and OHSS, we'll start with 75. Otherwise, I can start with 150 also in others.
So after age, one more important thing which I like was dividing them into PCOS and non-PCOS, or hyper responder versus normal responders. So Dr. Sandhya and Dr. Neha.
Yes, I agree with this. Yeah, I agree with this. That I would decide according to the response of the patient, whether the patient is a low responder or a high responder. If the patient is a low responder, I don't mind starting at gonadotropin 150. Sorry, if she's a high responder, I would start with 75, and a low responder with 150. And also depends when I am starting the gonadotropins. If I am starting earlier during the cycle, I would go with a lower dose. If I am just adding it up with the ovologens, like when I'm giving a mixed cycle, I've given the initial 5 days with clomiphene or letrozole, and I'm adding it on day 7, day 9, then I'll go with gonadotropin 150.
So let's hear a recent and younger view. Dr. Neha, what is your view? How do you do it?
Ma'am, as my co-panelist explained it very well, age, AMH, AFC, BMI, and the previous response, 5 factors.
That's excellent. I think you have compiled everything. So are you aware of this Sonos scoring system given by our very own Dr. Sonal Panchal? I just wanted to go through quickly. She has given a score from 1 to 5 for age, BMI, AFC, wherein volume, stromal RI, and stromal PSV. And according to this, score is from 6 to 30. Minimum is 36 and maximum is 30. So you can see that if age is more than 40, BMI itna, so a score will come to the minimum, and this patient will not be a good candidate for IUI, and she'll be requiring higher dose. And on contrary, if she's a hyper responder, all these comes to the max, she'll be requiring a proper monitoring with very cautious dose. So since many of our patients, they come into this category, so Dr. Hari was right in using 75 in a blanket way, so that fits to almost everyone. And according to the score towards higher responder, your increment of the doses will be smaller, and if a score is lesser, your increment would be higher. But I like this chart. This chart is very simple, though it was given for recombinant FSH, but we can just adjust it by adding 25 unit of HMG. So if your patient is below 45 kgs, 50 unit of recombinant FSH is too much. If she is somewhere between 45 to 65, use 75 international units, and beyond 65 up to 100 unit of recombinant FSH works very well. So this is a practical thing. So for most of the patients which we are working on, if they are hyper responder, as Dr. Sandhya said, if we start with lower dose of 75, then it is going to work well. So that leads to my next question. There are few people believe that let's recruit first and then we'll decrease the dose. Few people believe, no, let's start cautiously. So what is your preferred mode? I'll start with Dr. Ram Gopal.
I would start,
step down.
Yeah, I would like to be on the safer side for the sake of the patient as well as myself. So I would start with a step up.
Excellent.
So I would start with the step up. Yeah.
Neha?
A low dose step up protocol, and in PCO patient, very low dose step up protocol.
No, a step up or a step down?
Step up.
Okay, Dr. Satya?
Or IUI step up.
Step up. And Dr. Hari?
Yeah, it's obviously depending on the indication. In the sense, if it is for an ovulation, chronic low dose step up protocol, that is the rule.
So,
and if for chronic low dose, start with 37.5 or 50, or at the most 75. And for unexplained infertility, things are a bit different, where again low dose step up is the best one, but if it's an art, step down is the beauty of it. Start with 150 and close monitoring and step down at the earliest.
Choice of protocol, what do you do usually?
Yeah, that's right. Depending on the indication. If it's for PCOS and ovulation, it's chronic low dose step up. And if it's for other indications like unexplained infertility, it may differ, but mostly it's a low dose. It's not chronic low dose protocol, and very rarely step down. Okay.
Okay. And Dr. Jiten?
Madam, I will definitely go for step up protocol.
And Dr. Raju?
For IUI, more also step up protocol.
Step up. Yeah. So Dr. Hari's and Dr. Neha's division brings the next question. Do you people believe in using chronic low dose protocol for your IUI cycles, especially in India? Starting with 37.5 international unit for your IUI cycles. As per literature also, chronic low dose protocol is meant for monofollicular development and TIC. It's not meant for intrauterine insemination. You can use, there are exceptional periods when you have had a bad experience in the same patient, you had to cancel, so you can do it. But most of the time, our panelists are extremely right that we are using 75 international unit or a step-up protocol according to the indication, be it 75, 150, as per all the parameters we have already been discussed. I agree with you, Dr. Hari. But
in this context, may I ask our moderator and the panelists, how far you have gone with the stimulation for IUI? No, mine is 18 days. That's the best I could.
How long or how much dose?
How long? The duration of
I think I'll answer this because I actually congratulate Dr. Seema Pandey for raising this in a good platform like this. Because almost all the conferences when they go.
Dr. Raju, I can't hear you.
Yeah, first of all, I congratulate you for raising this very valid practical point. Because when of the almost all the conferences we go, when it's PCO, everybody will just say chronic, no dose step-up therapy is extending for 20-25 days. But in practicality, I never did it. And I studied in a very reputed institute, and there also my professor used to say that this will work for an academic institute, but not for practical purpose. Because in majority of time, I start from my own perspective. If it is a PCO patient, suppose a thin, lean PCO patient, my starting dose will be 75. And majority of time, I start along with the letrozole. And on day 10, I do a scan and see the response. And suppose I will say there is 1 or 2 follicles only growing, I will continue with the same 75 without much change. I will not reduce or I'll increase the dose. But if it is not a PCO patient, definitely I'll consider increasing the dose, and that should almost double the dose. But 37.5, then to 75, then to 118 point something, blah, 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 blah. I think that is practically is little difficult in my thoughts.
So, Dr.
I think there will be different opinion.
Excellent narration, Dr. Raju. Dr.
Sir, one question, sir.
Agree?
Sir, one question, sir. If that patient whom you did scan on day 10 had so many follicles and you fear that she is going into OHSS, so you had to cancel the cycle. So no, when you start in the next cycle, you start at the same
you just need to stop your stimulation. You just need to stop your stimulation. The dominant follicle will just grow.
Yeah. So next time when you stimulate, what dose will you use? Will you still use 75 or will you go to 37.5?
We can reduce. Obviously, we can reduce. We can go
That's
for 50.
what
That's
we
the beauty
said,
of
Dr. Ram Gopal, that if previous experience was as such that you got that hyperstimulation with 75 even, then you could think of going still lower, whatever suits for that particular patient.
So Raju, did you see the signboard? There's no going back.
See, the practicality, Hari. See, majority of the conference we listen this, and if you ask any of the not ART people, other routine gynecology they're practicing, they're starting with the 35, 37.5 and 50, 75, and start 7 or 10 or injection. Patient losing their money and nothing is happening, and ultimately giving register for a withdrawal bleeding. And when they come to us, we start with 75 and getting the patient responsive. So that is not the right way to communicate to the, routine gynecologists out there. Because the patients are there and we should aim for a response. And just instigating a fear of hyperstimulation for all patients is not the right way to do things. Obviously, we should have a very clear-cut understanding on how to cancel the cycle. When the follicles are 4 or more, we should cancel. That has to be certain. But just telling them that we should have suboptimal dose and just wait for it, and say, that's the patient time and money wasted for every time. I don't think that's a very practical way to go forward.
I completely agree with you. And whenever we are doing a gonadotropin cycle, this counseling goes hands in hands that if anything happens, we have to cancel. And in spite of taking all the precautions, similarly, as we are walking on road, we are driving on road, we are taking all the precautions, but sometimes we meet with unfortunate accidents. Similarly, in our practice, when we are stimulating, when we are using gonadotropin, sometimes hyperstimulation might happen. That is happening with CC as well. People are taking CC at home. And recently in Ukraine, that lady, she had 9 pregnancies, Ukraine or somewhere in that those Russian USSR countries. She had 9 children, and there is no history. But do you think it could be natural, or she might have taken CC? Because there is no record. So we can, just because accident will happen, we cannot stop moving on the road. Similarly, with all our gears up, we have to move ahead, and starting very, very low dose protocol for IUI is not practical, especially in a country where all the cycles are self-sponsored and patient has a lot of choices to change the doctor immediately after 14-15 days. That person will come back and say, you are just wasting my time, and putting those many injections every day, that doesn't make sense to me at least. So do my other panelists, they agree to this?
Yeah, madam. Yeah.
So Dr. Sandhya, how frequently do you change your dose? Suppose recruitment did not occur on 75 unit. So how long do you wait if patient is not a PCOS?
When whichever date I have called the patient for scan, after starting the gonadotropins, like 2 to 3 days, the 5th or 7th day, I have checked, and if the follicles have not grown, I don't wait. I do increase the dose that day.
So you must be calling either 5 injections or 7 injections. So accordingly. So yes. Dr. Ram Gopal, how do you do it?
Yeah, madam, we'll start the injections according to the patient profile, and then we'll call her after 5 to 7 days only after the start of the injections. Then accordingly, according to the scan, how many follicles are growing and the size of the dominant follicle or the leading follicles, then we'll call for scan earlier, maybe 3 days, maybe 2 days accordingly.
So yeah, so you just go from 75 to say 150. Or 75 plus 37.5?
150, 75 to 150.
You can double the dose also, but in some patients we might have to add only half the dose of half of the starting dose.
Okay, completely agree. So the next is all these details. Suddenly step down protocol. Dr. Jitendra.
Yes, ma'am.
Are you using step down protocol in any of your IUI cycles?
Madam, I have not used, but once I have used for one patient, for elderly patients, for getting better result, and I got the follicle also. So I have only less experience about the step down protocol, ma'am.
So it's good that you have to be careful. Dr. Raju, Dr. Sandhya, anyone or Dr. Hari wants to say something about this?
Actually, I was trying to tell it's an art. The step down is an art, because he should know when to step down exactly. Instead of monitoring once in 4 days, 5 days, you have to do it probably every alternate day. And you have to be very vigilant to identify the dominant follicle going past the 10 millimeter mark and immediately step down. And stepping down by 37.5 or 75, again, you have to think about how many have gone beyond the 10 millimeter follicle. And again, you have to maintain that lower dose for some more time to get it past the 14 millimeter to make it autonomous. So it's an art.
So Dr. Raju?
Same. In IUI, I have to be practiced, but in IVF cycles, definitely sometimes step down protocols was good for me.
So the message we want to give here, if your patient is hyper-responder, don't increase the doses very frequently. And if you have just started doing it, as Dr. Hari has clearly mentioned, it's an art. And there is a big learning curve getting used to. So you can very easily do it after 5 days, 7 days. In PCOS, the increment should be lesser and at longer duration. And in normal responders, unexplained infertility, you can even double the dose. And that according to the follicle, which is being shown on the monitor. That is the most important thing which we want to tell. So here comes the role of monitoring. So how many of you do your own monitoring? and how many of you are getting it done through your sonologist?
On.
Own monitoring.
On monitoring.
Own monitoring.
I think all of us are doing our own monitoring, no? So what are the things you are looking at? And how many of you are also doing hormonal investigations in your IUI cycle? And do you think there is any roll-off? And what are those situations? So we'll take monitoring here. So most of us are asking our patient to report after 5 or 7 injections, and then as frequently as required. That is about ultrasound. So what are the things you are looking at your first scan, and how are you following up? So Dr. Jiten?
Yeah, first we have to see how the total number of dominant follicles. If it is like more than 14, more than 4, then there is a high chance of hyperstimulation. And at the same time, if it is a leading follicle more than 16 and count is 3 also, there is also high chances of hyperstimulation. In those cases, we can directly go for estradiol, and based upon the value, we can go for the stimulation, means you can decide for the stimulation, or we have to cancel.
So Dr. Sandhya, are you using hormonal investigation routinely in your IUI cycles?
No, Dr. Seema.
Dr. Neha?
Not at all. Not at all.
Dr. Neha?
No, ma'am, not in all IUI cycles.
Dr. Ram Gopal?
No, madam, only ultrasound monitoring.
Okay, perfect. So Dr. Raju, can you tell us the situation where you go for hormonal monitoring?
Maybe one situation, suppose on day 12, suppose we started with the letrozole, say gonadotropin, and we do a scan on day 11, day 12, and we are seeing a 11 or 12 millimeter follicle. And we are waiting for another 2 more days and doing a scan, and it's more or less stagnant. And in those situations, definitely I'll, if suppose it's a recurring episode or some chronic patient, then I see the ovarian response along with estrogen level. So that estrogen will definitely help you in guiding whether the follicle is growing actually or not, rather than just by stimulating the patient. In that case, that may be the only situation I prefer a hormonal monitoring. Otherwise, I may not.
Okay, Dr. Hari?
Yeah, basically the rule is play to your strength. You have hormones, you have ultrasound. Ultrasound is your strong foot.
We have to hurry now. We want very quick and short answers.
You have to, you can do it yourself. So that's the best thing you can do. And in IUI cycles, estradiol evaluation, I don't think it helps in any way, except in a very few situations where when you face an OHSS threat, very few.
So, Dr. Neha, what are those situations for you where you do your hormonal monitoring?
Actually, I have not been able to do it in even a single case, because the place where I work in takes 2 days for report to come.
There's no need to. IUI cycles, they don't require hormonal monitoring. If you are doing a good ultrasound TVS scan, you never need. There are exceptional situations like no recruitment or more than 4 follicles. You want to convert this cycle into IVF, or you are not very happy with the growth of the follicle. You are suspecting premature LH surge. Those are the situations where E2 and progesterone monitoring may be required, and that comes once in a blue moon. So what are the common problems you encounter during your gonadotropin IUI cycle? OHSS we have already discussed, multifetal gestation we have already discussed. So what are the other problems, practical problems which we are getting? So I'll start with Dr. Ram Gopal. He is mute. Dr. Sandhya.
The only problem is like taking the injections. Some patients may have problem with the HMG.
Yes,
which has to be taken properly. The second thing is like unexpectedly when too many follicles come up, there's a confusion whether to cancel the cycle or convert it to IVF.
To say hyper response. Yes. So hyper response is of 2 types, or no response is very important rather. So it came first. So hyper-responsive, many follicles. That's why the first question was, if you are getting it done through your sonologist, most of the time they just report about your dominant follicle. They forget to give the cohort value, and that leads to confusion. So hyper-response is one thing, and no response if we are going with chronic low dose protocol, and we are waiting for that response to occur. What else, Dr. Raju? What other problem you see into your gonadotropin cycle? Dr. Jitain?
Yeah. Premature LH cells will be there.
Yes. And so, how do you tackle your premature LH surge? Dr. Hari, do you believe in doing antagonist IUI cycles?
No, I don't do personally, and going by the literature also, antagonist inclusion in the IUI cycles won't help you either in terms of improvement in the result, means live birth rate, or in terms of complications. I don't do.
Okay, we'll come to review of literature later. I agree with you, but
we have only 25% of premature LH surge, even in the IVF cycles where higher dose of gonadotropins are used. So we don't expect much of LH surge in the IUI cycles. Even otherwise, if she ovulates also, nothing is going to happen because we are doing an IUI in and around the 36 hours interval.
Okay.
I just had one practical
point. Yes, Dr. Raju.
I agree with Hari that's about evidence-based. But in some situations where I personally use this antagonist protocol, when this endometrium is going at par with the follicle. Suppose in gonadotropin cycles, we usually tend to give a trigger by around 17-18, and the endometrium is okay. Usually in IUI cycles, suppose I am seeing a follicle of 17-18 millimeter and the endometrium is not grown, and I'll just wait for some more time and the follicle collapses. In those sort of subset of patients, in this coming cycle, I prefer to give an antagonist cycle so that I can maintain this follicle growth still, say, around the endometrium to grow more than 7 or 8. That is the only time I do antagonist IUI. And honestly, I got 1 or 2 pregnancies by doing this procedure.
Dr. Jitain?
Yeah, madam, actually what sir told, it is perfect. And second thing, the timing of IUI also, it is very difficult, especially in weekend time when and sometimes the husband will be not available.
So are you using antagonist IUI in these situations?
Very rare, madam. I think out of 100, some one patient might have used.
Okay. What about Dr. Sandhya?
Only when I'm planning to convert the IUI cycle to IVF.
Okay, a very good indication, practical indication she gave. Dr. Neha?
Ma'am, I've never used antagonist in IUI cycle.
Okay. You haven't done anything wrong. Dr. Ram Gopal?
Yeah, madam, in the already mentioned cases, previous already we have, that there was a previous premature LH surge to avoid weekend IUI when there is an endometrial and follicular dysynchrony, and when I want to change it to an IUI.
That's an excellent add-on from you, Dr. Ram Gopal. So around 30% of our IUI cycles suffer from premature LH surge. But what Dr. Hari has said, that makes sense, that you're going to do the IUI in 36 hours. But that is a big reason of failure. And looking at the situation, a very interesting article by Ghulam Bahadur, I was reading, it is published in 2018 about reappraisal of IUI. And there he has mentioned that if we do our IUIs very nicely and thoroughly, we can stop 25% of subfertile population entering into IVF and ICSI cycles. So there comes the role of intrauterine insemination with antagonists. So foremost indication is your gonadotropin cycles, where you are getting supraphysiological values as compared to your oral ovulation with multifollicular. The most important group I consider, besides all the indications you have given, are those older patients beyond 35 with poor ovarian reserve and their follicular phase is very short, and they get ruptured below 16, and the endometrium, as Dr. Ram Gopal has said, asynchrony happens between endometrium and follicle. So when you want big follicles, you want to just go and take this thing out of your cycle, antagonist is really helpful. And if you want to improve your result, these are the indications where premature LS surge has happened, avoidance of insemination during weekend, and PCOS subpopulation, where these things happen very abruptly and you don't come to know about it. So those are the situations. So talking about Dr. Hari's point about this, that antagonist cycle doesn't improve live birth rate and clinical pregnancy rate. This meta-analysis came into 2019 over more than 3,000 patients, where their conclusion was that it doesn't improve your clinical pregnancy rate and ongoing pregnancy rate, but it improves your chances of premature luteinization and LS surge. But what has happened? When they did subgroup analysis, higher pregnancy rates were observed when all those RCTs which reached a statistical significance were taken into consideration, and IUI with antagonists made a clear-cut difference, which can be seen in this cycle. As you can see that gonadotropin plus antagonist IUI, if selected properly, brings out around 58% of result as compared to 11.5 and 21 and 25%. So adding your antagonists clearly, smartly, and as and when required gives you a power over improving your result. So there comes the next question: when and how do you convert your IUI cycles in IVF? So let's start with Dr. Sandhya.
In patients where I am expecting that this may happen, that more number of follicles would be recruited earlier, especially in PCO patient, I would give this hint initially itself. And I would like to know whether the patient is ready for this. So if the patient is ready, and then depending upon the second scan, like after the day 2 scan, when I call the patient on the day 8, that day I would decide whether this needs to be converted to an IVF cycle or not, depending upon the number of follicles that have been. If the follicles are more than 4 to 5 numbers, I would ask the patient whether she is willing, and if yes, I would start her on antagonist, and if not, I would cancel the cycle.
Dr. Neha, do you want to add something? Have you converted any of your IUI cycle into IVF?
Yes, ma'am. In few patients, and those patients we do counseling beforehand. So that
yes, that is very important. Yes.
So that they are mentally, financially prepared. And then as and when, if definitely we get a hyper response, we convert, we add anta, convert, and do freeze all. And then transfer, single blast.
Dr. Ram Gopal, your opinion?
Yeah, madam, same only. Few cycles only we have been fortunate enough or unfortunate enough to change from IUI cycle into IVF, and earlier counseling is the most important part, because you might be ready to change, but the patient might not be expecting the same.
Dr. Hari?
Yeah. After hearing Ram Gopal, there's nothing more to say. It's either fortunate or unfortunate enough to change. But my take is, our aim is different. See, when you are planning an IUI, you are trying to make a pregnant lady pregnant with a low resource setting. So cost is an important thing. Second, coming to the economics of follicular growth, you are dealing with an asynchronous cohort in IUI cycles, and compared to the ART cycle where we have a prepared cohort. And third thing, when we do have knowledge regarding downregulation ART to start at 14 millimeter antagon or at day 5 or whatever it's, but in IUI cycles, do you have enough literature when to start an antagon? So these things make it an uncharted waters, and I don't want to linger around.
So Dr. Jitin?
Yeah, same thing, whatever Hari Kumar sir has told,
okay, so I'll change my question. Dr. Raju, how fruitful these converted IVF cycles are? What is your opinion when you have converted your IUI cycle into an IVF cycle?
To be very honest, I haven't converted so far. I experienced 1 or 2 cycles during my studentship, and they were successful.
So there are 2 schools of thought, and most of the literature is before, I think vitrification was not that prevalent, those people, first school of thought that if you are converting an IUI cycle into an IVF, it does not give good result. But nowadays, when we are doing freeze all cycles, these cycles can really be rescued by converting it into IVF. If you are doing only gonadotropin cycle, you have added antagonist on time, you are doing proper monitoring, provided you have done the counseling beforehand. So we are promoting that in spite of wasting your resources, if you convert it, if you cannot convert on your own, you can refer it to your friend or colleague. And if this cycle can be rescued, her follicles can be taken out, and later on a frozen cycle transfer FET can be done. So here comes the last question, I think. When do you cancel your cycle? So I'll start with Dr. Raju, and 1 point each from your own personal
Cancellation is pretty
experience, so
simple,
that
madam.
our viewers
If
can
the
be
follicle number is more than 4, 100% cancel. Because conversion to an ART cycle, as
When
Hari
do
said,
you cancel?
8
How
months.
many follicles, Dr. Raju?
4 or more dominant follicles.
4 or more dominant. What about you, Dr. Jiten?
Madam, more than 3 and it should be more than 16 millimeters.
And Dr. Hari?
Yeah, I'm liberal, closer to Raju.
Okay. Dr. Sandhya?
More than 4 follicles, I do cancel.
Dr. Neha?
Ma'am, more than 3.
Okay. And Dr. Ram Gopal?
Same, madam, more than 4.
Okay. So all my panelists, they are
Or if
ready.
the patient is not, or if the patient is not willing to change it to an IVF cycle also.
Exactly.
Now,
So
again, one more thing, you have to consider the intermediate follicles also. Don't go by the, if you, when you say 3, 4, you mean to say about the dominant large ones?
Dominant follicles, and what about the cohort which is following? You have
Exactly.
to look at that.
Intermediate follicles.
Yes.
Intermediate follicles, as conventional wisdom says, they contribute to the OHSS, but most of the recent papers say they can contribute to the multifetal gestation also.
They are the contributors for all the factors responsible for OHSS. So yeah, we have to look into that, and very strict cancellation policy should be followed. It should be pre-counseled. And most of my panelists, they agree that they don't go beyond 3, 4. Once you cancel the cycle, and Dr. Jitin, can you tell me, what do you tell exactly to your patient? What should they do? What should they not be doing?
Yeah, when the patient will come for the, means regarding the cancelling the cycle, madam, you mean?
Yes.
Yeah.
When
So,
you have decided to cancel,
yeah.
how do you counsel the patient? What all the things you tell the patient that they should follow?
Yeah, patients, first of all, we have to tell that if you are sees proceeding with this high number of dominant follicles, so what are the consequences going to face, that we have to explain in details all the symptoms, everything of the OHS, and we have to give the add-ons to prevent OHS, and we have to explain the symptoms. If she is having any problems, she has to be noticed to us as soon as possible. That's all I can say, ma'am.
So what about like giving progesterone, having intercourse or not, or all these things?
Yeah, intercourse, definitely, madam. Intercourse he has to avoid. And second thing, progesterone we have to give, and we can give cabergoline also, and metformin also. If she is on metformin, that has to be continued. And if possible, you can give cetrolix also for 3 to 4 days.
Is it? All these
just
things
for 3
to give
follicles.
just at the time of cancellation. When you are just asking the couple to avoid intercourse, you have not given SCG or your trigger. Why do you need all these things? Dr. Raju, what is your view?
In my practice, I just do 2 things. One, I give a GnRH agonist trigger, and I'll ask for abstinence. That's all, nothing else.
Okay, that makes sense. Dr. Jiten, you were speaking right now. I couldn't see who was Dr. Hari or Dr. Jiten who was talking earlier.
No, actually, I would like to add something and be on record that you have done this. You have asked them for barrier contraception or abstinence. Because tomorrow, if any problem arises, just be on record, not like a verbal thing.
That's a very, very important point, Dr. Hari. You have brought it down. That's why I put this question. So to be medico-legally safe, along with the patient safety profile, that is also important for us as a doctors. So anything else, Dr. Sandhya, do you want to add? Anyone?
I should tell the patient and make her aware about the seriousness if she doesn't follow what we are saying. So I should tell her about what would happen if she has intercourse and if she ends up with pregnancy. These things can happen, about the OHSS risk and about the follow. So I would also tell her to take high protein diet and drink lots of water. And in case of any bloating, feeling, something like that, she can come over. But usually in 3 to 4 follicles, all these things don't happen. And if she avoids abstinence, if she does abstinence, that itself is enough.
So yeah. And how many of you are giving all this cabergoline, metformin? Metformin at PCOS, she's already on metformin, that's good. But if she's not taking, she wasn't taking it earlier, are you people giving all these things once you have decided to cancel the cycle?
Definitely.
So anybody wants to add anything?
We can give progesterone for the withdrawal bleeding as soon as.
Yeah, that is also a good thing. That is the only thing which can be done that can bring out that estrogen level to the normal as soon as she gets period. But even if we don't do that, that is not mandatory. And what we want to give the message is, once you have cancelled the cycle, you have been given the trigger in form of SCG, then the chances of going her into OHSS are almost nil. So you don't have to take those precautions and those medications which are being given for treating OHSS. That is the main thing. Abstinence is the key. You have to explain the importance. As my panelists, they repeatedly told that proper counseling, documentation, and all these things are really important. So it was such a nice panel, and all my esteemed panelists, they were just overflowing with knowledge and wisdom, and the kind of feedback we got for our audience and viewers, I hope it was helpful for you. Just before winding it up, we would just like to revise things. Whenever patient come on day 2, 3, or 4 of cycle, you are planning for gonadotropin or any cycle, do a TVS, just rule out any residual follicle, and as per her previous response of OHSS, age, AMH, FC, AFC, you decide your protocol, use gonadotropins with proper monitoring, same timing, don't go for fancy things, do whatever works for you and your patient, and maintenance of cold chain in using gonadotropin goes a long way. So keep looking at that. And any injection which you are making by mixing the powder and solution should not be kept for half today, half tomorrow. And no matter whatever you do, OHSS has happened. As in obstetrics, we say, if we have not done any complication, that means we are not working enough. Similarly, in ART and reproductive medicine and infertility, problems are bound to happen. The smartness is that how smartly we are coming out of it without harming our patient as well as ourselves. So this is all for today. Thank you so much for such an excellent share. And in the end, not the least, I would like to thank my President, Dr. Prakash Trivedi, and Secretary, Dr. Kedar Ganla, for giving me this opportunity to interact with all these lovely people. And thank you, ISAR Kerala chapter and MCure for this wonderful platform. And my panelists, you all were awesome, awesome, awesome.
Thank you, Dr.
Thank
Seema.
you, audience. Thank you. Of you, we are here and talking.
Thank you, Dr. Seema, and all the panelists. It was a wonderful discussion. And
hello, ma'am. Namaste. How are you?
And those people who are genuinely interested in infertility treatment have remained to attend after the ART pregnancy. Some have left, but the people who are remaining were really interested in hearing your panel discussion.
So we are open to any question, Fessy, if they have.
Yes, it was a wonderful panel, Seema. Even even that after 1:30, still we have got more than 90 people who are logged in.
Oh,
And
I'm really sorry. We went really long, and
we will
I
quickly
tried
take
to
2-3
keep it very
questions.
short.
Yes, yes. One question is sir, by Dr. Arun Kumar Singh. What dose of HCG if 3 follicles?
So, any of my panelists can take up the question. Yes.
Yeah, if you're going to give HCG, I would prefer it to be 10,000 because 5,000 can be underdosing at any situation. So if you are deciding to cancel, it's a different issue. If you're going to give 10,000 will be better.
Can I ask one question, Dr. Hari? How do you decide that it's going to be underdose 5,000? I've never exceeded 5,000 until unless my patient is 90 kgs plus.
Fine. I'll come to it. In the sense, in an ART cycle, actually you need to give a lower dose because you are going to pick here in the IUI cycle. If you're planning an ovulation to happen, it has to be a higher dose compared to an ART cycle. So whatever we give in ART, it's 6,500, 5,000. It should be more in the IUI, unlike the thing which usually we think.
But
I'm not aware of this fact. I think 5,000 is enough. How many of my panelists they agree to this statement?
5,000 is almost a universal prescription. I never gone beyond 5,000 for the past 16 to 17 years.
Starting from 1,500, 1,000 to 5,000, 10,000, everything works. And one limit arbitrary was taken as that 5,000 international unit or 250 milligram works for almost this range of BMI. The dose of SCG becomes like insufficient in people who are obese, whose BMI is more than 32, 33, 34.
The core idea of the question was whether if the follicles are more, 5,000 or 10,000 makes a difference in terms of OHSs.
Okay.
So that was the answer I was trying to give.
Hari, if your aim is of prevention of OHSs, the more the dose, more chances of OHSs now. Yeah. So you should try to reduce the dose.
No. If there's a chance of OHSs, I am very much towards cancellation rather than giving an HCG.
If you have to give, then you will go towards minimal dose, no? Not towards 10,000.
Yeah, that is exactly what I am telling. 5,000 and 10,000 won't make a difference in terms of OHSs.
No, it will not. Why don't you give agonist?
Madam?
Dr. Sandhya.
I would like to go give
agonist. Problem with the agonist is that, problem with the agonist is why you want to give agonist. You don't know whether it is going to the OHSs or not. But I think everybody should keep a very low tolerance limit towards the OHSs threat. If you have the least chance, if you're suspecting anything, go for cancellation rather than giving an agonist trigger, which will definitely. Please.
Dr. Sandhya wants to say something then.
Yeah. If it is 3 follicles, I would like to go with the GnRH agonist. And there's also a dual trigger in case the patient is obese and you're doubting about the HCG dosage. I can add a small dose of GnRH agonist like Piperacillin 0.1 mg to the HCG 5,000. That would be.
So I would like to add one point here. You all are right in your own sense, but the thing is, you have to remember that OHSs occurs mainly to PCOS population. So you'll have to see the background of those 3 follicles. If this 3 follicle is happening in a patient of unexplained infertility or a normal responder, poor responder, she is not going to get OHSs. We are more worried about multifetal gestation in these patients. And even if you give 5,000, it's not going to do any harm if patient is not PCOS with an intermediate cohort of so many follicles together. That is the most important thing we have to understand, that SCG works bad only in presence of these hyperresponders who are underlying polycystic ovarian syndrome. And they have some different kind of idiosyncrasy for getting OHSs with SCG. Rest of the population on 3 follicle is not going to get OHSs with 5,000 SCG. But even if you want to be on careful side, as Dr. Sandhya said, you can go for dual trigger or double trigger. You can give 2,000 or 1,500 of SCG along with GnRH analog trigger. GnRH analog trigger alone does not work in IUI cycles except in situations where there is folliculoendometrial asynchrony in a CC cycle. That is the only indication for GnRH agonist as a trigger in an IUI cycle.
I think one more question is, what is your opinion of timing of IUI if 3 follicles, whether it is 36 hours or double IUI? I think that there is a difference of opinion. There is two different class of people practice. Some people confirm ovulation and then do it. Others just blindly do it after 24 hours or repeat 2 double IUI. So there is no definite consensus. I think that answers that question, I think. And then there is another question, which is anonymous attendee. Do you suggest start with 75 unit for chronic low dose protocol or insert 37.5? That I think Raju rightly told during discussion. No, there is every conference we hear about that, but it's not practically in our setup, because in Europe, where the most of it is done under the health scheme, where patient cannot go for any other place, they go for these protocols. Otherwise, practically, I don't know. Others just can please answer that question. Nobody's answering that question. Okay, because very few people does that. Okay. Then next question by Dr. Arun Kumar is when to start ANTAG in IUI cycles?
Nobody knows.
I think he is asking about the size, if they have to incorporate.
Maybe.
Yeah, so then you have to go according to flexible protocol when your follicle reaches around 13 to 14.
No, ma'am. We are scared when the follicles are much bigger.
Pardon?
So generally, we are scared, and when we decide for IVF little later.
No. I'm not talking about that. I'm talking about gonadotropin antagonist routine IUI, where you have already decided that you're going to do an antagonist cycle. There you follow flexible protocol. Once your follicle reaches 13 to 14 mm, you introduce antagonist as we do in flexible protocol in IVF. And rescuing is a different story. I think question was this.
Okay, I think so. Then one interesting question which we did not discuss much is that what about cold chain difference? Is there a difference between powder form and refill syringe preparations?
So any one of you, whosoever wants to take the question?
Other than that, regarding the reusage of the reconstituted one, I don't think any difference.
The powder form has a longer shelf life.
Okay,
as,
one last
as long
question
as not
by Dr.
reconstituted.
Shobha. Okay, but the cold chain is very important, and that is the one which has to be really seen in people when you tell the patients to take it from their home itself, or we have to make sure they maintain the cold chain.
Yes, right, President.
Yes, one question is from Dr. Shobha is, I always get a single follicle with HMG. How to get 2 or 3 follicles?
So she'll have to increase her threshold level for next time and extend the phone. Yeah, please do. Anybody.
If it start, the HMG has to be started earlier during the recruitment itself. If she starts earlier during day 2 or day 3, then she will get multiple follicles.
You are mute.
Sir, you are mute. Fesi, sir.
Yes, if any other point or question is there, can you just discuss, because Dr. Kedar is joining.
Oh.
And because he was busy with some other panel. So any other point is Sadi Madam want to add any point which was missed out or anything?
Pardon?
No, I just wanted to clear the point that about giving GnRH agonist in IUI cycle.
Yes, ma'am.
The GnRH is going to act on the pituitary and cause release of LH, which will act on the hypothalamus, release LH and cause discharge.
Pardon, ma'am, I didn't get the question.
Agonist, we are making use of the flare effect of the agonist. Cause LH surge. Fair effect of the agonist to cause LH surge, and that can cause follicle rupture.
You mean to say it brings rapid luteolysis?
No, no, I was talking about in IUI cycles.
Yes,
where
ma'am.
you use, can't hear. I was talking about in IUI cycles where you use GnRH agonist instead of HCG to prevent OHSS when you are suspecting development of OHSS.
No, ma'am, that's what I was trying to tell, that our IUI cycles are entirely different than our IVF cycle. The way agonist works in our IVF cycle doesn't work in a similar manner in our IUI cycle. Here we are not doing any kind of oocyte retrieval and that rapid luteolysis. The only advantage of agonist I was mentioning as per literature was where there was an asynchrony between the follicle size and endometrium in CC cycles, and second as a dual trigger in terms of the way it brings ephesus surge as well. It might improve the quality, though we have paucity of literature over there, but I follow dual triggers in most of my cycles in IUI too.
The threat of multifetal gestation is still there, even if you could ward off the OHSS.
I think Dr. Kedar has joined.
Yes, Dr. Kedar has joined.
Secretary General, because we had a good attendance, nearly 150 people were attending the live, in addition to the YouTube people attending. Kedar, can you give any message or anything?
No, thank you, Fesi, and Kerala chapter for giving this opportunity to conduct this webinar. I just wanted to know whether you all, did you see, all of you all see the video which we prepared for the ISAR activities, and I'm very be very happy all of you to participate in these activities in a big number by taking the advantage of Dr. Sadhana Desai Endowment Fund, Empathy Fund. Do an application. All your poor patients can benefit out of it. Get your centers accredited so that when the ICMR accreditation comes, it will be easy for you to to undergo the accreditation process. And the membership, now it is very simple online membership program. So it is, I think it's very easy. One-time payment, 8,000 rupees for clinician, by which they will become your member also, Kerala chapter member and the central ISAR member. So I come to be very, very beneficial to everyone. And once
22 members have joined. 22 members have joined. I think the application is in the office. That is more than 40% of our present membership.
So, and increasing the membership, FESI has taken, and Dr. Pillai also has taken a great initiative in increasing the awareness of and membership drive for ISAR. Thank you very much, everyone, for being part of this wonderful panel discussion.
Thank you, Dr. Kedar, for this opportunity.
I think so.
And thank you, Fesi and MCure. Yeah.
Thank you. Sadi madam, can you
Thank you so much.
conclude, madam?
Yes. We had a wonderful discussion on 2 topics today at very short notice. And even though I was not expecting such an attendance, Kedar was sure that we would have a very good attendance. We had a very good attendance, and the discussion was very, very good.
Thank you.
I can only thank all the panelists and the moderators for conducting such a wonderful session. Both the webinar, both the panelists were very good, and we had very good attendance, and it was very knowledgeable. Thank you, all of you, especially Kedar for initiating.
Thank you.
I must thank Amit from MCure. He's always been there. I think Amit must have seen more webinars than anybody else in this whole time of lockdown. Thank you.
Definitely, sir. It has been the support of all the doctors like you. We are able to complete 231 webinars till date. and we have all the archive, and it will be freely circulated to all the IVF specialists soon. Thank you so much for your help in this, achieving this.
Okay, thank you.
Thank you, Satya ma'am. Thank you, Fesi sir.
Thank you very much.
Thank you all the panelists and all those who are attended. Thank you.
Ma'am, Sima ma'am, bye bye.
Bye. Thank you, guys. You people were really awesome. And let's be in touch and do more.
Yeah, ma'am. Bye.
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 Bye, Dr. Kedar and Dr. Fesi.
Bye.
Bye, ma'am. Bye, Neha. Bye, Dr. Sindhya.
Bye, Dr.
Bye,
Sindhya.
ma'am.
Thank you so much. Thank you so much.
Thank you, Amit.